Good afternoon, everyone. Welcome to the CME on the clinical updates for doctors in rural service. So just before a couple of quick instructions, it would be nice if everybody could turn their video on, but please mute yourself throughout the entire CME, otherwise it becomes quite disturbing since there are over 200 registrations. Also, if we have time for questions at the end of the talk, you can post them there's a little Q&A message access to everyone on the side. You can post your questions there. If we don't have time to answer or the talk goes over time, we'll move forward. You can still post your questions. We will answer them and get back to you. So now we're going to start. I will hand over to Dr. Prithvi Dasari, who's our General Secretary of the Alumni Association. Thank you.
Hi, everybody can hear me?
Yes, Prithvi. Yes.
Okay, thank you. Thanks, Anjali. It is a pleasure to welcome all of you for this CME. It's organized as part of the academic initiative of St. John's Medical College Alumni Association. This CME is especially for doctors who are working in the rural and the underserved areas, and we are truly value the dedication and commitment you bring to this community. A special thanks to Anjali for leading this effort, because the topics and speakers have been very carefully chosen, and we have sort of ensured that these sessions are very relevant, practical, and that are helpful in your day-to-day clinical work, right? So we hope you find these sessions engaging and informative, and they support in your important work you do every day. Once again, welcome all of you, and thank you for being here. Please be proactive, ask questions, right? Some of these speakers are familiar to you and some of them are not. But believe me that all of them have actually put in a lot of effort to bring the CME about, right? Thank you. Thanks, everyone. Welcome.
Okay, so since we are very short on time, we'll move on. So the first speaker is a UGPG alumnus, Dr. Shreya Raskina. She's from the Department of OBG at St. John's Medical College. So I will let Dr. Shreya start. Thank you. Shreya, just give us a second. We'll share your screen.
Sure. Very good afternoon to all of you. I hope I'm audible.
Yeah.
Yeah, very good afternoon to all of you. Thank you so much, Dr. Anjali and Dr. Prithvi, for this session, and thank you for this honor. I would like to begin my presentation. Today, I will be talking about the recognition of high-risk pregnancies, new labor care guidelines, and emergency obstetric care. Starting with recognizing a high-risk pregnancy. To do this, you need to know what a high-risk pregnancy is. Any pregnancy where there is a higher than normal chance of maternal or fetal or neonatal complications occurring before, during, or after delivery is a high-risk pregnancy. Factors that can make a pregnancy high-risk include maternal age, such as young age or teenage pregnancies, advanced maternal age, especially primigravida over the age of 35 years, existing health conditions, which could include hypertension, diabetes mellitus, obesity, PCOS, thyroid disorders, renal disease, cardiac disease, autoimmune or hematological disorders, infections, etc. Lifestyle factors like use of tobacco, alcohol, and drugs, and pregnancy-related conditions such as gestational diabetes mellitus, preeclampsia, hypertensive disorders of pregnancy, multiple gestations, any previous cesarean sections, previous preterm births, bad obstetric history, pregnancies by artificial reproductive techniques, and fetal anomalies. Now, the Pradhan Mantri Surakshit Matritva Abhiyan in 2024 has listed 25 such categories of high-risk pregnancies, which is nothing but a repetition of the previous slide, and it's a more comprehensive list of all that. So to screen for high-risk pregnancies, we need to cover history, examination, and investigations, which I'm sure we're all doing in our day-to-day practice. But of note here, I would like to mention on examination, the BMI of a patient, rather whether the patient is overweight or obese, plays a huge role in determining risk factors, because obesity itself is a risk factor and also has associated complications with it. Apart from this, in investigations, all these are important: hemoglobin, TSH levels, random blood glucose and fasting blood glucose, as well as screening tests like the GCT and the oral glucose tolerance test, which is a test to detect diabetes mellitus in pregnancy. Also, HbA1c levels are of utmost importance in diagnosing gestational diabetes mellitus, as well as the glucose control throughout pregnancy. Apart from this, imaging is also important, particularly the NT scan, and along with it, the uterine artery Doppler, which also is an important predictor of fetal outcome in future pregnancy, especially fetal growth restriction, and also is a good predictor of development of preeclampsia later on in pregnancy. So Dopplers play a very important role here. I would also like to talk about the inverted pyramid of antenatal care. Now, conventional antenatal care as we know it involves routine antenatal visits, the once a month visit up to 28 weeks of gestation, followed by once in 2 weeks, followed by every week after 36 weeks is what we've been following everywhere. But the inverted pyramid of antenatal care emphasizes on prioritizing first trimester screening for any high-risk condition, particularly maternal complications and fetal anomalies, over routine antenatal care visits. This does not mean that we disregard low-risk patients completely. We do need to follow them up on a regular basis, but screening for high-risk conditions in early pregnancy just helps with the risk stratification and early identification and management of these complications, leading to better outcome. So this will help with early detection of conditions like gestational diabetes, preeclampsia, fetal growth restriction, and therefore we can tackle these conditions much earlier. We could also stratify these patients according to their risk, probably color code their OPD charts, OPD records, and maybe have different days of the week when we see high-risk patients and different days of the week when we see low-risk patients, more frequent visits for high-risk patients. All these are implementable the way you like at your centers with whatever you're comfortable with. It will just overall reduce your workload and also help in more effective care and more efficient use of resources. Another scoring called the gestosis scoring I would like to emphasize on. Many a times the uterine artery Doppler may get missed or may not be done, or the importance of it is not understood. In this case, certain scoring systems come into place, and one such score is the gestosis score. So certain risk factors, like I mentioned earlier, things which you can elicit on history, things like age, presence of anemia, obesity in the patient, previous history of any hypertensive disease, any pre-existing high-risk factors. All these, when you look at it, they are classified as mild, moderate, and high-risk factors with scores of 1, 2, and 3. Addition of these points for any risk factors that are present, if the total of the score is more than or equal to 3, it indicates a high risk of developing preeclampsia in later pregnancy. In such cases, it is a good idea to start the patient on ecosprin from around 12 weeks of gestation itself, or as early as possible in pregnancy. 150 milligrams of ecosprin daily from the beginning of pregnancy up to around 34 weeks of gestation can help curb the incidence of fetal growth restriction as well as development of preeclampsia in pregnancy. Obesity, as I mentioned earlier, is an important high-risk factor. It can lead to complications in pregnancy, including gestational diabetes mellitus, hypertensive disorders, preeclampsia, preterm births, postpartum complications such as postpartum depression, etc. Obesity is a high risk factor for these, but also it affects the fetus. There can be high incidences of stillbirths, large for gestational age babies, macrosomia, and congenital malformations. Long-term fetal outcomes also include overweight, obesity, type 2 diabetes mellitus, and cardiovascular disease. Long-term maternal outcomes also, such as overweight, obesity, type 2 diabetes mellitus, cardiovascular disease, or strokes. New labor care guidelines. I would like to talk about new labor care guidelines, which developed by the WHO are a tool for implementing recommendations on intrapartum care for a positive childbirth experience. In 2018, the WHO came up with recommendations to improve the quality of essential intrapartum care with the ultimate goal of improving maternal, fetal, and newborn outcomes. This also includes something called the Labor Care Guide, also known as the Next Generation Partograph. The WHO intrapartum care model, at the center of this model is individualized and woman-centered labor and childbirth. This includes a clear medical indication for any intervention which is implemented, and not only promotes interventions which serve an immediate purpose, but also those that have a proven benefit. It emphasizes on a positive childbirth experience for the woman, the newborn, and her family. This model emphasizes on having a birth companion specifically, which was not a recommendation earlier, but now is. So a birth companion chosen by the patient, probably a close friend or a partner or a family member, who can help support the woman throughout labor, and also emphasizes on good communication between the healthcare professionals looking after the laboring woman, which may be the midwife or the obstetrician, and communication of any developments during labor, the progress of labor, presence of any complications to the woman and the birth companion. The WHO Labor Care Guide is an adaptation of the conventional partograph and includes 7 sections. It's pretty much the same as the previous partograph with 2 additional components here, which are mainly the supportive care, like I mentioned, the presence of a birth companion and also use of any labor analgesia, and also the section 7, which is shared decision making, which is basically the communication of any decision which needs to be made, clear communication to the birth companion and the patient. Apart from this, this begins with plotting of the partograph at cervical dilatation of 5 centimeters, which is taken as active phase here, and also has a separate plotting of the progress in a separate column that you see on the extreme right, which is second stage of labor. So this can be used to monitor the well-being of a mother and baby during delivery, and it also helps prevent any unnecessary interventions in labor and supports audit and quality improvement. It can be used for all pregnant women, especially low-risk women, with additional and specialized monitoring and care for any high-risk women. It can be used at all levels of care. In fact, I would recommend that you try to implement this in your settings as well. This documentation is begun in the active phase, as I mentioned, which is taken as 5 centimeters. Coming to labor emergency obstetric care, which is the last topic of the day. Emergency obstetric care refers to certain life-saving interventions that must be available to women with life-threatening complications during the antepartum, intrapartum, as well as postpartum periods. Availability of these is crucial in reducing maternal and neonatal morbidity and mortality. This includes basic emergency obstetric care. This includes administration of parenteral antibiotics, mainly for infections, administration of parenteral deuterotonics for postpartum hemorrhage management, which I will be speaking about in more detail later. Administration of any parenteral anticonvulsants like magnesium sulfate in case of preeclampsia and eclampsia. Manual removal of placenta in case of retained placenta, and removal of any retained products in cases of miscarriages and incomplete abortions. Also, assisted vaginal deliveries like use of vacuum and obstetric forceps. Comprehensive emergency obstetric care involves all these 6 basic components, in addition to which surgical interventions such as cesarean sections and blood transfusions in case of very severe bleeding. Postpartum hemorrhage. Now, the 4 T's glare out at you. Maybe you remember it back from your MBBS days when you studied obstetrics in final year. These include tone, trauma, tissue, and thrombin. Atonic PPH or reduced tone of the uterus leading to hemorrhage is one of the most common causes of postpartum hemorrhage. Following this, there is also trauma, which is no less common. This includes lacerations and hematomas of the genital tract, which need to be repaired in order to stop the hemorrhage. Also, in addition, there is tissue. Tissue is another component, which is mainly a retained placenta or any retained products of conception. And lastly, but not the least, is thrombin, which is mainly any coagulopathy. Coming to this, I would like to talk about a care bundle approach and thereafter the emotive care bundle approach. A care bundle approach is a healthcare strategy which focuses on delivering a set of evidence-based practices together to improve patient outcome rather than using individual components in whatever order. It results in consistent and reliable implementation and promotes standardization of care and quality improvement. And very often, since this involves multidisciplinary teams, it helps enhance communication and teamwork as well. So this emotive bundle approach involves early detection of postpartum hemorrhage, uterine massage, oxytocic drugs such as oxytocin itself, methogen, carbetocin, misoprostol, etc., tranexamic acid, IV fluid resuscitation, and also examination of the genital tract and escalation wherever necessary, and treatment for refractory PPH. FIGO has recommended certain care bundles for PPH management. The first response PPH bundle includes uterotonic drugs, like I mentioned earlier, isotonic crystalloids. Tranexamic acid is an important component here, which I feel is not being sufficiently or appropriately used in several places. Tranexamic acid is highly effective and is actually a wonder drug, and it can work wonders in PPH management. This along with uterine massage. Therefore, when PPH is detected, the first response is to initiate fluid resuscitation along with intravenous administration of uterotonics. In case of non-availability of these, fluid resuscitation along with sublingual misoprostol is equally effective, or any other uterotonics for that matter. In case of any placental retention, the retained placenta needs to be extracted and antibiotics started as well. And if any lacerations are encountered, they need to be repaired by suturing. A response to refractory PPH includes compressive measures like aortic compression or bimanual uterine compression. Intrauterine balloon tamponade is also effective, and non-pneumatic anti-shock garment. All these are measures that can be implemented in the process of transfer or referral of a patient to a higher center. A continuous use of uterotonics during this response to refractory PPH, as well as a second dose of tranexamic acid, is also effective and must be used along with this and should not be neglected. Availability of these services, the first contact or your usual antenatal care, your regular antenatal care for low-risk women occurs in your health centers and health posts. Basic emergency obstetric care is available at maternity hospitals. Along with this, comprehensive emergency obstetric care is available at peripheral and tertiary care hospitals. Therefore, appropriate referral is of utmost importance. The continuum of obstetric care begins with awareness and recognition of high-risk factors, like I began in my presentation. Basic care, regular follow-up, and timely referral for any high-risk pregnancies is of utmost importance. Antepartum care, which is women-centric, and labor monitoring, especially using the WHO Labor Care Guide, is recommended. Along with this, emergency obstetric care where indicated, and prompt referral as well. Along with this, any delays in seeking emergency care must be avoided, and high-risk factors and need for timely referral should be emphasized on. To summarize here, I would like to mention certain important things. One is not to neglect noticing a patient's BMI and presence of obesity. Even in a non-pregnant woman, it is very important to pick this up early and recommend lifestyle modifications in order to curb the incidence of obesity, which is a growing pandemic these days. Make use of facilities such as uterine artery Doppler if available, or if any reports are available on this. It's a very good predictor of future pregnancy outcome. In the absence of this, or even in the presence of which, scoring systems such as the Gestosis score can be very important, and initiation of aspirin administration at an early gestation is also very important. Risk stratification by screening and early pregnancy is also important, and risk stratification can help reduce the burden on the burden of care on our centers as well, by stratifying patients into low risk and high risk, and thereby escalating care where necessary, having more frequent antenatal care visits in case of high risk pregnancies. Also, in case of PPH management, I would like to again re-emphasize on the use of tranexamic acid, which is very, very helpful in PPH management, and use of the emotive bundle approach rather than individual components. To use all of these, including early detection, uterine massage, uterotonics, as well as tranexamic acid and IV fluid resuscitation. And last but not the least, I would also recommend the use of the labor care guide recommended by WHO, which can really help smoothen out the entire labor care process. That's all for my presentation. Thank you so much, everyone, for your attention. And I would like to end by something a senior told me, which is help will always be given at St. John's for those who ask for it. Thank you. Any questions are welcome.
Yeah, we have time for questions. If anybody's either anybody can post questions. Okay, if anybody wants to ask any questions, yeah, we do have a question, Shreya. What is the role of carbetocin?
Carbetocin is good for PPH prophylaxis as well as, for PPH prevention as well as treatment. It can be used as a uterotonic in case of PPH. It is heat stable, and if available in your centers, you can definitely use it.
Maybe you can tell them how to use it if somebody doesn't know.
Yeah, so it can be given. It can be given in an IV infusion in 100 ml of normal saline. 1 vial of carbetocin can be given intravenously. A slow IV it can be given along with uterine massage and other measures as well, along with vitals monitoring and monitoring the amount of blood loss. Someone mentioned Bakri balloon. Balloon tamponade is also effective. Balloon tamponade is also effective. Bakri balloon tends to be more expensive, but if available in your centers, it can also be used. Bakri balloon can also calculate the amount of blood loss as and when it is happening. If available, it can definitely be used. It provides an internal sort of tamponade which helps compress the uterus and reduce the bleeding. SR cannula.
Yeah, there's one more. Thanks.
SR cannula or the Panikas cannula is also an effective measure. It provides some sort of suction. By introducing it into the uterine cavity, it helps compress the uterus with the suction, and it also helps measure the amount of ongoing blood loss as well. So the cannula can be introduced into the uterine cavity and kept in place, and the amount of blood loss measured as and when it's happening in real time. So if available, if SR cannula is available, you can definitely use that sensitize, sure.
Yeah, so I just want to say thank you to Dr. Shreya. That was, I mean, I know it's a really vast topic and it's very, very important. So it's quite difficult for you to.
So I'm sorry, someone said I was quite fast. I was just trying to keep to the time and cover everything.
No worries.
I'll share the slides definitely.
The slide, we're also recording this, but the slides will also be made available.
Yes. Okay. Sure.
Okay. Thank you so much, Dr. Shreya.
Thank you.
The next presentation we'll move on to. The next presentation is from our Department of Neonatology. As you all know, it's one of the top departments in this country. So it is by Dr. Chintana on something that's very simple, but also very, very important on kangaroo mother care. Dr. Chintana, if you can start, please. Where is Chintana? Sorry, she seems to have a problem joining. Just give her a minute. In the meantime, if anybody has any questions, even on this topic or any other topic, you can still post it. And at the end, we will have a feedback form which has questions at the bottom. So you can ask those questions if you remember them somewhere in the course of the day.
Anjali ma'am, can you hear me?
We can hear you, Chintana.
Can I start the session?
Yeah,
now?
please, please.
Slides, I can move or you will do it for me, ma'am?
No, you will be given control of the slides, Chintana.
Okay. Okay. Good afternoon, everybody. I'm Dr. Chintana. I'm SR Neonatology from St. John's Hospital. Today, I'll be talking to you about kangaroo mother care. As we all know, I think most of you are practicing kangaroo mother care already. And especially in a rural setting, kangaroo mother care is a very important intervention which has shown to help in reducing the mortality, reducing the infections, and it is a very low cost and easy intervention which can be easily implemented. So kangaroo mother care is a special way of caring low birth weight babies. It helps in health and well-being by promoting effective thermal control. Also promotes breastfeeding. It helps in infection prevention, and also it helps in the bonding between the baby and the mother. So coming to the components of KMC, as we all know, there are three important components of KMC. One is skin-to-skin contact, early, continuous, and prolonged skin-to-skin contact. Exclusive breastfeeding. Kangaroo mother care promotes lactation and facilitates feeding. It ensures adequate nutrition for the baby. And it also helps in the desired weight gain, which would result in early discharge and follow-up care. So this is the Cochrane review, which shows the numerous benefits of kangaroo mother care. It is shown that it reduces the mortality by 40%, 65% reduction in sepsis, 75% reduction in hypothermia, 88% reduction in hypoglycemia, and 58% reduction in hospital readmission. So these 4 to 5 are the main important morbidities in newborn care, and it is shown that to significantly improve in all these areas. So I think we should try to implement KMC as much as possible. It is also shown that it improved the exclusive breastfeeding rate at 1 to 2 months, and also the anthropometric parameters were better in the babies who received KMC. So, sorry. So coming to the criteria for starting KMCs, which baby should we initiate KMC? So it is advised that all babies gestation who are less than 37 weeks, irrespective of birth weight, or if the baby's weight is less than 2.5 kg, irrespective of the gestation, we should try to initiate KMC in all these babies. In our unit also, we are following this protocol. If the baby's birth weight is less than 2.5 or the gestation is 37 weeks, we initiate KMC for those babies. So coming to the timing of initiation of KMC. KMC can be started as soon as possible. So as soon as we feel the baby is hemodynamically stable, does not require any bolus, inotropes, or any other intervention for hemodynamic instability, and the vital parameters of the babies are stable, we can start the KMC immediately. It can also be given in babies with IV fluids, OG feeds, or oxygen, CPAP. With all these parameters also, it can KMC can be initiated. Here you see the picture of one of the baby from our units who is on who is a preterm around 31 to 32 weeks of gestation and is on CPAP respiratory support, and we have initiated the immediate KMC to the baby. So what is immediate KMC? Immediate KMC is starting KMC within 2 hours after the birth. So this was the WHO IKMC study, which was published in 2021 in NEJM. It showed that starting KMC in low birth weight and preterm babies, that too within first 2 hours of life. So even if they had requirement of respiratory support, IV fluids and all that, had significant reduction in neonatal mortality. So IKMC is what we have implemented in our unit also, and we have even done a QI study to achieve a IKMC rate of more than 80%. So all babies who are hemodynamically stable, irrespective of their respiratory support, we try to initiate KMC within the first 2 hours of life. It is very safe and feasible in a tertiary care center. So to initiate IKMC, what we have started in our unit is mother newborn ICU. You see here immediately. So here the mother is still admitted requiring intensive care. Baby is also in NICU. Both are together, and it has facilitating in starting the IKMC in our setting, and also under the leadership of Dr. Suman Rao ma'am from our unit. Even in Polar, we have started the IKMC unit. So IKMC is very helpful in initiating the KMC, and also it helps us to give family-centered care and prolong KMC to the baby. So coming to like when we are starting KMC in our unit, how do we have to prepare? So first thing is counseling of the mother. So to achieve a good KMC and good duration of KMC, it is important to counsel the parents, both father and the mother, explain them the benefits of KMC, how long it has to be done, how it has to be done, and also to the other family members, the procedure has to be explained. In our unit, any preterm baby, low birth weight baby which is coming into the unit, either ward in the this one, the primary doctor or the nurse will counsel the family about the kangaroo mother care. So counseling is an important step in initiating the KMC. So how do you prepare a KMC? So as we know, KMC is the low cost intervention, does not require any equipment, any major equipments or cost involved. The only thing is you need a proper facility to make the baby sit. So you can either use the KMC chairs or the reclining beds, which can be used to provide KMC. So here you see the mother in our unit, and and mother should wear an appropriate clothes. So it should be a front open light dress according to the local culture. We advise them to wear a front open shirt or a gown, which can be worn during giving KMC. Baby, usually we undress the baby, make the baby wear only cap and socks and nappy. Maybe a front open shirt it can be worn by the baby. So as you know, we can do it either with the KMC chair or also with the a reclining bed can be used to start KMC. Positioning. We gently place the baby in between the mother's breast in upright position. Head should be one side, turned to one side and slightly extended so that the baby can be breathing easily. Hip and flex should be abducted. Baby should be like in a floor. Baby's abdomen should be touching the mother's epigastrium, and mother should support the baby's bottom. So here you can see in our unit, in our ICU, one mother is doing the KMC. Baby is held in a frog-like position and head is turned to one side, and baby is kept in between the mother's breast. So apart from keeping that, in our unit, what we use is the KMC binders. This picture shows you numerous binders which can be used to provide KMC. This will help in holding the baby for prolonged time. Even sometimes mothers, while giving KMC for long duration, they sleep in between. So it is very safe and it is recommended to use binders while giving KMC so that the baby doesn't slip off and KMC can be done easily. So as you see here, in the first picture, mother with the twin babies is doing KMC. They have helped her with the binder and she is able to easily walk while she is carrying the baby. And KMC is not only an in-hospital practice. We have to tell them to continue KMC at home also during discharge. So here you see a mother is doing KMC held with a binder, and then she is able to do her household work easily while she is doing KMC. So that is important of the binders. One most important thing is monitoring during KMC. These small babies have to be continuously monitored during KMC. So the neck position, we should always tell the parents to maintain the neck position. It should be neither too flexed or too extended, so they can breathe easily. Airway should be clear. We have to monitor for their breathing, color, temperature. Here you can see in the photo that the nurse is checking the temperature of the baby while they are giving KMC. Parents can also be advised to touch the baby now and then and feel how the baby feels warmer. And in the second photo, you see the nurse is instructing the mother to see the pulse oximeter. This is one of the things which is very important, especially when we are doing IKMC or doing KMC on babies on respiratory support. We should instruct them to continuously see the monitors and inform the sisters if any problem is seen. So even feeding can be given in KMC. This is what we practice in our unit also. KMC, we know, will promote lactation. It will help in mother in producing more milk. So the breast milk, even the OG feed, Falada feed, everything can be given in KMC. As you see in the first picture, a nurse is giving OG feeds while the father is doing KMC. In the second picture, while the aunt is giving, sister is giving Falada feeds. And it is very good to do direct breastfeeding also while in KMC. So this is one of the, in MNICU or in any other setting, mother at home, she can take rest while she's giving KMC to the baby. So coming to the KMC in your units, so if the KMC currently you're doing practicing, and if you feel that you're not able to achieve good achieve the target, so you can do QI projects to improve the KMC in your unit. So here is one of the study which was done in a outborn unit center where they found that their KMC initiation was very low. They found what were the difficulties in the policy, place, people, and process. What were this one? And with the numerous implementations of the PDSA cycles, they were able to achieve good amount of KMC they could do. So, so coming to the duration of KMC. So KMC, how long will you tell the parents to do? KMC should be provided for at least 1 hour per session. As we know, the newborn babies have a sleep cycle of 1 hour. So at least one sleep cycle of the baby should be completed while they are in KMC. So we instruct that when the parents or the attendant sits for KMC, minimum of 1 hour at least should be completed. It can be done to a minimum of 8 hours per day or continuous. If KMC is provided for more than 20 hours per day with brief interruptions for hygiene and feeding, it is called continuous KMC. Continuous KMC is shown to give good outcomes to the baby. Prolonged KMC, in our unit, we encourage the mothers to give at least a minimum of 8 hours of KMC. So coming to the discharge and transport, as you know, in the rural settings, most of the times you will have to transport the baby to the higher center for further, and you will not be for further management, and you will be not having incubator facilities, all those things for transport. So KMC is a good mode to transport the babies. So you can, while sending to the higher center or while sending home, you can send the babies on KMC. It is very good practice to do that. So that is the end of my talk. If anybody has any questions, we can take up. So conclusively, I want to tell that KMC is a very low cost and which can be done easily in a rural setting or in smaller places, and it is very easy to do it. So we must try to implement KMC as much as possible, and it is shown to give numerous benefits to the baby and the mother also.
Thank you, Dr. Chintana. We have, I think, time for 2 questions. If somebody wants to post their question, they can do that, or if you want to ask, okay, you can ask the question. I think 1 second, somebody's. Somebody wants to ask a question? If you can post the question, then Dr. Chintana will be able to answer it in the chat box there. Somebody put up, okay. If there aren't any questions, then we can move on to the next one. Thank you, Dr. Chintana.
Thank you,
I understand how simple this was, but it's also how important it is and can be done in almost any setup. So thank you very much.
Thank you.
So the next talk we have is by our sister, Dr. Malti, who is currently the medical superintendent in St. Francis Hospital in Ajmer. She's both UG and PG Johns, but there is something that, I mean, of course, everybody finds very difficult to use and very difficult to understand, which is antimicrobial resistance and rational antibiotic use. So if Sis Malti is ready, we can start the next one.
Yes, Anjali, I am ready, and thank you for that introduction. Can you hear me?
Yeah, we can hear you.
Yeah. So I think we began with an obstetrics. We went to the pediatric a little bit, and then now we are coming to antibiotics. And I believe that antibiotics is common to all fields. So I'll just be speaking, though the topic is quite vast. I have just tried to restrict myself to what I would like to focus on, and not the really detailed thing of it, thinking that probably the basics we are aware of it. So I begin with that. So what do we say about the antimicrobial resistance? When do we say? We just say the antimicrobial resistance when we know that one antibiotic was acting against an organism and now it's no more effective. So that's when we call it as resistance. So we come across these terms. I have just put it across what is MDR. And MDR just would mean that, say, for example, a Pseudomonas. Normally, for a Pseudomonas to be, any antibiotic to be active against Pseudomonas, we have a various groups. For example, aminoglycosides would work against Pseudomonas. Fluoroquinolones will normally work for Pseudomonas. We have penicillins, for example, piperacillin, tazobactam, meropenem. These things normally work for Pseudomonas. And if we have more than one or one agent in more than 3 groups, say, for example, all 3 groups which I have mentioned earlier, Pseudomonas is not, I mean, the antibiotics are not effective against that Pseudomonas, then we would call it as a multi-drug resistant organism. What do we call it as XDR? XDR would be that the organism actually is effective or it's susceptible to less than two category of agents. When do we call pan drug resistance? We would call when it is resistant, all the groups are resistant. I mean, nothing is working on the patient and we are left with actually a lot of, we are trying to do some research on those things. We are giving combination therapies, or we are trying to work in a different mode of deliveries. For example, colistin, we would try to give it in an inhalational route when things are not working in a normal way. So in those situations, we'll call it as pan drug resistant organism. Coming to the next slide, please. Coming to the mechanism of antibiotic resistance. We know that the antibiotic resistance can develop in many ways. So look at this picture and you will find that either the organism is not taking the drug or it's taking the drug, but there is an alternate drug target. The third one would be the target is same, but it is getting inactivated by the drugs or the enzymes inside the organism, or the drug is gone inside, but at the same time, it's getting effluxed and it's not remaining inside the organism. So we have simple thing. Either the drug is not getting inside. Second one, either it's not acting on the, I mean, the target itself is changed. The second one is there is getting inactivated by the different enzymes. And the last one, what we call it as the drug is as it is getting exported out from the organism. So drug actually is not getting affected inside the bacteria. You know, the next slide, it looks quite crowded. And all of you who can see it, it's so the antibiotic resistance, to speak also, it's as crowded as what the slide can look. It's very complicated. But at the same time, it's a day-to-day problem that we are having. So if you look at, because since I began with antimicrobial, it includes bacteria, fungi, HIV, tuberculosis, malaria, parasite, anything, any bugs you call it. And these, most of my data, I have taken it from the World Health Organization. As you can see it to your right, in the right columns, which I have put it. In the bacteria, 76 countries, 42% of E. coli is actually resistant for the 3rd generation cephalosporin. And we have the incidence of MRSA around 35%, which is quite a huge number. We have fungi. And those of you who are getting used to it, we must understand that Candida now no longer, as we used to look at, that is a common cell in the oral cavity, in the genital tract. You can find a lot of common cell Candida. But at the same time, now we are coming across species which are no more getting killed by the usual fluconazole or whatever drugs azole. So the usual drugs that we were giving earlier, coming to HIV. And these data actually are alarming that nearly half of the infants newly born to the HIV mothers, they have drug resistance to NNRTLs. Shocking. Tuberculosis, we know that actually India is one of the leading countries where we have a excessive global burden of tuberculosis. And we find that this MDR, we are finding 27% of global burden is in India. And we are finding that 1.1 lakh cases for MDR TB. And only 2 in 5 people with MDR, they have access treatment, which means that we are just having what percentage of people we are just detecting, which means the data is not available to us. We have malaria, which is again endemic in India. And this particular data is taken from African countries, and we are finding that there is artemisinin resistance. This is again taken from World Health Organization. And so the antibiotic resistance is a big, big problem. But at the same time, we must remember with what solution we can come out. Now, as you can see in the next slide, what is the WHO priority list? Which are the organisms which are causing and they are standing in a red zone, which we need to be very, very careful about. So you can see in the first column, as you can see it, that is a critical priority. One is carbapenem-resistant Acinetobacter baumannii. And those of us who are dealing especially with the critical care patients, we are dealing in day-to-day practice and seeing this in culture. And we know how difficult it is to treat Acinetobacter baumannii. Very rarely can we treat this organism with one antibiotic. We will have to always add either a second antibiotic and look whether it is having a sensitivity pattern, what type of pattern it is having. The next one is carbapenem-resistant Pseudomonas. The third one we have in this list is carbapenem and third generation cephalosporin-resistant Enterobacteriaceae. That is, we have Klebsiella in it, we can have E. coli in it. So we have these organisms which are actually a critical priority according to WHO. Then we have high priority. In the high priority there, we can see vancomycin-resistant Enterococcus faecium. Then we have clarithromycin-resistant Helicobacter pylori, fluoroquinolone-resistant Salmonella species, vancomycin and methicillin-resistant Staph aureus. We have fluoroquinolone-resistant Campylobacter species. Then we have third generation Cephalosporin and fluoroquinolone-resistant Neisseria gonorrhea. These are all come under high priority list. And then we have the medium priority list, that is penicillin non-susceptible Streptococcus pneumonia, ampicillin-resistant Haemophilus influenza, and again we have fluoroquinolone-resistant Shigella species. And we know that especially the high priority and medium priority we come across every day in our practice. Now, I'm sorry, the previous slide. When I was preparing this slide, the first part was actually easy for me to prepare the slides. The second part I found, what should I speak to people like us? Because we are working in a very resource-limited rural setups. What to do when we find that these kind of organisms could be present? Because the second part of my talk, there is a rational use in rural India. Where is the basic data? We don't have. Because from rural India, whatever data we have would be either from an institute, which is educational institute, or coming from a metropolitan city. In the rural India, where is the data? That is the thing, to base our research or base our practice on what do we rely on. Second thing, how do I diagnose? Because I don't have people doing culture. How do I diagnose that these bugs may be resistant? What do I treat? Because our patients may not be able to afford those drugs at all. So I would like to ask you one question. Where do you like to focus? Do you like to focus on what can or what you cannot? So I would say that let's focus on what we can, I have two pictures before me. Can anyone recognize? I have given their names. One is father of epidemiology. Can you answer, please? Anjali, can you help me out? So we have father of epidemiology and we have father of hand hygiene. Has anyone answered?
You can just post the message if it's easier for you on the site.
They can unmute and say as well if they would like.
You can unmute also. I think
See, so I move forward. Yeah,
Somebody-
I know someone has raised a hand.
someone raise your hand. You can just unmute yourself and answer.
Joseph Lister, second one.
Joseph Lister, second one, she said.
Yeah, so actually that is wrong. The father of hand hygiene is Ignaz Semmelweis. And you know, when he has seen that there is lot of maternal deaths in people who have done their autopsy and then come and conducted a delivery. And he found that people actually who are conducting at the outstation areas and not in the hospital, the maternal mortality were less. So he found that with a simple practice of hand wash, you could actually bring down the deaths in females, in mothers. So, you know, that today we know that what is the importance of hand hygiene. Okay. In those days, neither you know the bugs, nor you know the treatment. The only thing you know, and you are trying to incorporate the two findings. You are finding that people who have done their autopsies, the medical practitioners, and come and conducted a delivery, the maternal mortality is more in those patients. And there is less of maternal mortality in people who have not conducted the autopsy. So he found that after a hand wash, there was a reduction in the maternal mortality. And to my left, I have the father of epidemiology, that is John Snow. We know that at that time, we didn't know what is cholera. We didn't know what is the treatment of cholera. But one thing John Snow told is that there is a water supply, it's happening from one source, and people who are getting the water supply from this pump, they are dying of cholera, and probably they are having the disease. So we understand that actually speaking, a prevention is a key. And we know that everything, any antimicrobial resistance that is coming, so prevention is the beginning and the end of our circle that we are having the problems with. And we need to focus on those things that we can easily do. 5 moments of hand hygiene. We cannot forget this. Okay, we cannot forget when we should wash our hands. So hand wash is as good as what we started with, and we know that the Ignaz Semmelweis, how he brought down the maternal mortality. And then we know today that hand wash is the backbone of our infection control today. Coming to, again, I told you what we can do. So for any antimicrobial resistance, there are 2 sets of things that we can do to prevent it and to curtail it. One is non-pharmacological methods. Another one is pharmacological methods. But most of the time, what we do is we focus on pharmacological methods, whereas non-pharmacological methods are more effective, more lasting, because it actually is focusing on our behavioral practice. I have put too many things here. You can just read it. What is the core features of antibiotic stewardship? So you can look at that. So many things are there which comes in the preview of antibiotic stewardship. And this is the most important aspect whenever we are dealing with any antimicrobial resistance. I'm not going to read up this. You can always read up what is the antimicrobial stewardship. So I will come to the non-pharmacological interventions, and all of us can do it. Even at the national and international level, we are trying that these things come into picture and they come into practice, and that will be giving us a long-lasting effect on the antimicrobial resistance. One is hand hygiene, vaccination, and we should also ban on over-the-counter antibiotic drugs. We know that in India, it's so easy to get an antibiotic. Probably it will be more difficult to get a pack of salt, but it will be very easy to get antibiotics at our doorstep. We need to keep an antibiotic stewardship. Then we have national policies of antimicrobial resistance, international policies, water sanitization and hygiene, reforms in agriculture and animal husbandry. We know that there are many bugs which get resistant once they get into the system, ecosystem, for example, in agriculture or in animal husbandry. And then these things are coming to human and they are creating a lot of antimicrobial resistance. So we need to look. And we, as in rural practice, as I told you, let us focus our attention on non-pharmacological interventions, which will give us a more lasting effect and results on antimicrobial resistance that as it prevails today. As I told you that another arm to the prevention of it or the interventions are pharmacological interventions. And pharmacological interventions, as we know, are more finance consuming, time consuming, requires a lot of expense of the country and not available to everyone in the country. Okay. So there are simple questions. Now I am coming to the core of our discussion today and a little bit of my practical knowledge that I will try to give you. I have not gone into the detail of a lot of things which actually antibiotic resistance entails. I have gone into the simple things I would like to do. So whenever a patient is coming to us, let us first ask these questions. That is there an infection? If you don't have an infection, kindly do not administer the antibiotic. Or if your level of suspicion is less and you have 90% chance that it may not be an infection, kindly do not administer the antibiotic. So where is the infection? It's very important. And I would like to tell you that where is the infection is as important as is there an infection. So for example, if you are having an infection in the lungs and you give an antibiotic which doesn't reach the lungs at all, say for example, you have nowadays daptomycin, which can be given for gram-positive MRSA organisms. You are trying to give the daptomycin to a patient who is having a lung pneumonia. You must know that daptomycin doesn't work in the lungs. Second thing is that, say for example, we are having a patient whom we are giving metronidazole. When we are suspecting a gram-positive organism, along with the anaerobe, metronidazole will not work. So where is the infection? Third thing is that we are looking at, say for example, if the infection, the source is the skin, and we are not giving any gram-positive coverage, then it will not be effective at all. So where is the infection is a very important question that we need to ask. The third question that I have mentioned is source of patient. We are asking where is the source of the infection. We should also ask what is the source of the patient. Whether the patient is coming from a community-based area or a patient is coming from a hospital area, or even if patient is coming from a community-based area, whether he has approached the healthcare facilities multiple times in the past. These patients have more likelihood of having an infection which is drug resistant. The next question, what is the likely bug? As we are coming to know that there are many infections which would be bacterial, fungus, it could also be anything. It may not be a bacteria which will get treated with the antibiotic that we are administering. So we need to have a pre-antibiotic administration suspicion and a strong suspicion before administering the drug. The next is it likely to be resistant bug? I already spoke about it. What is the treatment? As I told you already, say for example, if you're suspecting an tuberculosis in a patient, there is no point in giving to that patient a piperacillin tazobactam antibiotic for another 5 days, 6 days. Patient is paying from one side and we know that it's not going to be effective. We are more likely that we get so used to giving an empiric antibiotic that we forget that we were like, no, whether that treatment will be effective to that patient or not. Probably one thing is that non-availability of data, non-availability of diagnostic techniques, and we think that probably by giving that antibiotic, patient may get better. Next is, what is the dose? It's very important for us to know the dose from every point of view. First point of view is that in sub-therapeutic levels, the drug may not be effective for the patient at all. And we may think, and next thing is that at sub-therapeutic levels, patient may develop resistance faster than otherwise. So we need to know exact dose of the drug. How long should the treatment be given? There are some drugs which should be given only once a day. And we have very limited, for example, azithromycin being given. Whether patient is in ICU, whether patient is in community-based infection, or patient is admitted to the ward, most of the time, the azithromycin, we give it for 5 days, maximum duration. Once a day is the dose, because the azithromycin will be released for 24 hours a day in a patient's body. So we need not give azithromycin for 10 days, 15 days, if we are thinking that the patient which actually benefit from the azithromycin. Next and the last, which is more important, is how to prevent the spread. because we know that from this patient, this particular resistant bug can actually spread to the other. So on the right side, I have given you the magic word, which is a right. So we need to reach to right diagnosis, right drug, right dose, right duration, right patient in the right place. For example, if the patient is requiring an ICU, I think we should be treating the patients in the ICU. If the patient is requiring the drug in the community-based setup, we should give it in the community-based setup, and the right prevention. So I think out of all the slides that I have discussed, this is the most important and practical slide that I have placed. Coming to the next, I know that when you look at this particular chart, it is taken actually from a very simple Wikipedia source. But I think Prithvi is online. If he is there, he would understand that till we are studying our patients who are in critically ill setup, once you look at this, a lot of your doubts will get clarified. And I would like you to, in your free time, to go through this particular slide. You go through it and you will find that you have gram-positive organized cocci, you have gram-negative bacilli, you have gram-negative cocci, you have anaerobes, and you have atypical organisms. And if you come down and you visualize and you see that which is the antibiotic which would work on these organisms, you will have levoflox in the atypical group, you have azithromycin, and you have doxycycline. Similar thing, you have anaerobes. And can you see in this list? Because I see a lot of people prescribing metronidazole for every aspiration that patient comes with. For example, we have the aspiration pneumonia, and you will find a patient getting a cephalosporin. Along with that, you will be giving metronidazole. Or patient is getting amoxiclavulinic acid, or patient is even getting a meropenem or piperacillin tazobactam. And along with that, we are very happy to provide the patient with metronidazole. My dear friends, let us stick on to the antibiotics, which I mean with our complete knowledge of what antibiotics do to the patient. So if we are giving amoxiclav to the patient, it will cover anaerobes. We don't need to add metronidazole unless we are suspecting that this anaerobic organism is the main source. Say, for example, if the source is the small bowel, or if the source is the large bowel, or there is a peritonitis or something we are suspecting. Only in those cases we need to add metronidazole. Or say, for example, we have added for a patient who is come with a diabetic foot, and if you have added a clindamycin, we know that clindamycin actually works for a gram-positive. As you can see on the left side, it works even for to certain amount community-based MRSA. You also have MSSA, that is the methylene-sensitive Staph aureus, and it also works for the gram-negative, anaerobes. So along with this, most of the time, I need not add patient metronidazole. So we need to always have that portion. Say, for example, I am adding patient meropenem, and I am giving to the patient meropenem. I know that MSS, methicillin sensitive Staph aureus is there. It will get covered with meropenem. Meropenem will also cover gram-negative. It will also cover anaerobe. I don't need to give any other additional antibiotic to this patient unless there is a resistant bug that I am expecting. So similar thing, I would like you to go through this particular chart and you will realize that a lot of antibiotics we are giving without really knowing its coverage. And it's difficult at times to really remember what the coverage of an antibiotic would be. So let us look at this coverage. And I would like you to pay attention to this. Can you see this? Our old friend, that is Bactrim. Bactrim covers MRSA. It covers methicillin-sensitive Staph aureus. Bactrim covers gram-positive, gram-negative. It also covers gram-negative cocci. So it has got a very wide range of coverage. So in a resource-limited settings, we can use this. But at the same time, you have a word of caution. You know that Bactrim is a drug which can have any amount of side effects. Sulfur drugs can cause any amount of drug interaction. Sulfur drugs can cause any side effects to every system in the body. For example, you will have hematological issues, you can have brain issues, you can have liver issues, so hypersensitivity reaction. So tributylmine along with the sulfamethoxazole can cause any type of drug interactions and also allergic reactions. So be careful whenever you are administering. Similar thing, when you are giving azithromycin, you look at azithromycin, it has got gram-positive coverage, azithromycin has got gram-negative cocci. You also have atypical organism with azithromycin group. So whenever you are administering a drug, have an idea of what that particular drug would do to the patient and to the organism. and it will help. So more and more, if you are paying attention to this particular slide and seeing the one antibiotic or antibiogram. Along with this, I would like to tell you that we need to know the antibiogram of the local region, which is very important. And I know that in most of our setups, it will be very difficult to get an antibiogram. But at the same time, looking at the patient's response, maybe for after a certain days, we need to take a call of what we want to do. Another thing that I would like to pay your attention to. Please, whenever a patient comes with a pyrexia of unknown origin, many of the times we all know that most likely diagnosis wherever we will be focusing is tuberculosis. I have put here in pyrexia of unknown origin only the bacterial causes which we come across, and which are like we are always left with the diagnostic dilemmas, and we need to do higher tests to diagnose this. Say, for example, we may be dealing with tuberculosis. Are you dealing with brucellosis? Are you dealing with Burkholderia? And I think that in rural setup, we may be aware, all of us may be aware of tuberculosis. Some of us may be aware of brucellosis, but very few of us might have come across Burkholderia. Because Burkholderia is an organism which will cause multiple abscesses across the patient's body. It can cause a brain abscess, a liver abscess, a lung abscess, or in genital tract, you look at the urinary bladder, you look at the prostate, you will find a different variety of abscesses, and you realize what am I dealing with? Patient is not getting treated with anything. So let us keep our index of suspicion high. We may be dealing with Burkholderia, and Burkholderia can present with these kind of abscesses. So let us deal with it with a diagnostic technique. And if we are not able to deal, let us refer the patient to a higher place where it could be treated appropriately. Then we have brucellosis. And we know that most of our rural public comes from a place where we have a lot of cattle and they are very close proximity living in the cattle. So brucellosis may be a possibility in them. And we know that I'm just telling you a very, very superficial treatment. Brucellosis will get covered with rifampicin. We have streptomycin with that. And Burkholderia. Burkholderia will be covered if we OPD basis, we are giving, it's very difficult to treat Burkholderia. So if we are giving it, say, doxycycline, we again have our old friend Bactrim, which can be given for Burkholderia. Other drugs that can be given and work well on Burkholderia are meropenem and ceftazidime. So let us look at these before we name anything as resistant organism. Now, I think this slide is not meant for the group that I am talking to. I have just put it that because as the WHO has said carbapenem resistant, we know that carbapenem is one of the same meropenem, imipenem, ertapenem. These are the group of drugs which is not functioning against the Enterobacteriaceae. And we have now, most of us would have heard about, say, for example, clavulanic acid. We have heard about sulbactam. We have heard about tazobactam. And some of us may be aware of avibactam. But we must know, dear friends, now we have other drugs coming up into picture. And especially when we are dealing with this gram-negative, especially in these, we have Klebsiella, E. coli, Enterobacter, and we may have Pseudomonas. In these patients, these are the genetic or genomic classifications that we have, KPC, MPLs, and OXA48. And this is like when we do biofire, when we have adequate resource to the patient, when we are doing the biofire or multiplex PCR, we get to know that these organisms may be a resistant strain. And then we give according to what is known, that is avibactam, vababactam, relebactam, these drugs according to the sensitivity report. I'm not going into the detail of it. We know that these are quite beyond our reach at times. Coming to the next drug, this is the same thing I'm dealing with. Whenever we are suspecting an NDM, we are suspecting OXA48, when we are sending NDM and OXA, we can have polymyxin-based therapy. Polymyxin-based therapies, colistin and polymyxin B. So colistin is polymyxin E and polymyxin B we have as it is. So when we are suspecting OXA48, we have ceftazidime and we have ceftazidime and avibactam combination. And whenever we are suspecting NDM and OXA48, we need to give ceftavi along with aspirin. So I'm just moving forward fast because this would only be appropriate when we have the genomic or the gene-related or the resistant strain diagnosis. Now, I'm not going into detailed evaluation about the gram-positive bacteria. We know a detail of it. We come across gram-positive bacteria. Most of us are aware that Streptococcus and Staphylococcus is the one which we are dealing with. Say, for example, a simple throat infection or a skin infection. What I want all of us to remember is that many times when a patient comes with a diabetic foot, patient may just be having a streptococci or staphylococcus, but patient may be really sick. And what we do is we go ahead and start the patient on vancomycin. But we must remember that vancomycin doesn't cover this toxin that is released from this organism. So for a toxin-mediated gram-positive infection, we will have to give a clindamycin coverage. And clindamycin will cover the toxin. At the same time, it will cover the MRSA or MSSA, whatever the patient is covering. And clindamycin also covers the anaerobic infection. So when we are giving an anaerobic coverage and we are giving a gram-positive coverage, and we are suspecting that there may be a toxin release or patient is having a toxic shock or a toxic syndrome, specifically in a skin-related issue, add clindamycin. It's a wonderful drug. Then in MRSA, what is happening today is that, see, these are only the slides I have put it out of my practical information that I have been dealing with. MRSA, we are dealing, and we know that the first drug we would go for is vancomycin. But we know all of us that vancomycin is an IV drug, and which becomes quite difficult for us to have an access or even expense or vancomycin interactions and side effects. So what is happening nowadays, more and more we are using, which is a drug, linezolid. There are a hell of other drugs. I call you that daptomycin is there. We can use it for gram-positive coverage. Okay, we have teicoplanin in which we can use it. But in a resource-limited setup, we would actually bounce back on linezolid. But dear sisters and dear friends, let us remember that linezolid should be used only if there is a vancomycin resistance. Because actually we are misusing a drug which has to be a spare drug when the vancomycin doesn't work. So we should use the linezolid as a spare drug and not use it as a convenient drug, which is very, very common in our practice that we are using. And to be, I don't think many of us are aware of the linezolid side effects when it comes to, because it's available as an oral drug. Linezolid can actually cause a psychosomatic illness. Patient can have a lot of neurological illness, a behavioral tantrum whenever we are using a linezolid on a long term. And second thing is that very, very important, it can cause any type of cytopenias. For example, it can be pancytopenia, bicytopenia, thrombocytopenia. These are the two very important side effects we must remember about the linezolid whenever we are thinking that the bug that we are dealing with may be an MRSA. Coming to enterococcus, and I am sure, 100% sure, because I myself was very much not a practical thing about enterococci. But yes, sisters, keep in mind and that enterococci can actually cause resistant strains. Earlier, it was called in Lanceville classification group D streptococci, and it cannot be killed by meropenem. So whenever you have an enterococci, it's a gram-positive organism. You need to either give a MRSA, and whenever you you have to give it a vancomycin coverage. And if you are having a vancomycin resistance, then go for linezolid. Because we see in our practice, actually, if you go and do a culture, we will find a lot of vancomycin resistant enterococcus. And we must remember that on this enterococci, meropenem is, I think, the higher antibiotics that in rural practice that we use it doesn't work. So we will have to give to the patient either vancomycin and vancomycin resistant, then let us go on to linezolid, where it will be suitable for the patient. Coming to anaerobes, and I think I have spoken enough about metronidazole, because metronidazole is one of the drugs which is quite a bit unused and misused and overused, not unused. And I already explained to you where we can use clindamycin and not need for metronidazole addiction. So with this, I think I was the longest in my talk. I have put one reference. It is in the Lancet, because we have a very little known about the resistant organisms. So this is a good paper which is telling you about the bloodstream resistant organisms. It's from India also, is there. The study is done in India, and you can refer. Thank you.
Thank you, Sister Malti, and thank you for breaking down such a complex topic. I know we gave you quite a task. So anybody has any questions can ask it later. We'll move on to the next talk. The next talk is by Dr. Murtaza Ghia and Dr. Vaishnavi, who are both, Murtaza is the founder of Code Blue and a senior clinical fellow in the NHS, and Johnite. He will start, followed by Dr. Vaishnavi, who is also a consultant pediatrician, but a co-director of Code Blue. So Murtaza, go ahead.
Excuse me, I would like to know for scrub typhus azithromycin, how many days you can use? Sister Malati was telling only 5 days maximum.
Yes.
Sister,
so if you are suspecting an azithromycin, you are suspecting, I'm sorry, can you hear me?
Can we Malti, can we
yes.
could you post the question and then you can
Yeah.
answer it on the chat, please, so that we can move
Yes,
forward?
yes, we can do that. Yeah, sure.
Thank you.
Sure.
Thank you so much.
Okay. आ गई ना वो सिस्टर? हाँ, 2 आया ना, ठीक है। तो ये सिस्टर मोरिन को ट्रांसफर करना है।
सिस्टर मुझे स्टार्ट करना है, आप आपका माइक म्यूट कर दीजिए। I'm wondering, hello, is this visible? So I've actually shared the screen, so I'm assuming this is right now. Is that correct?
Yeah, we can see. You can see. Go ahead.
Super. So big question to all of us is which special, when you look at this slide, any conclusions? And I've done this multiple times, gone across various parts of India and asked them what is the conclusion. People will always say, oh, this specialty is high, this specialty is low. But actual real conclusion of this slide is that all specialties are equally at risk. There is no specialty that is not at risk, because the lowest here, as you can see, is 40%, which means this sort of burnout, which is workplace related, is inevitable. Whichever specialty you're working in, you are going to face it. So obviously, I probably went through it because I'm a bit of a character in my own self. So I can't blame it on the system completely. And the bigger problem was not because I went through it. I think everybody goes through it. It's my unhealthy coping mechanism. So what I did, I chose the easy options. 1, you can see there. 2, Netflix and soft porn. Sorry, popcorn.
Murtaza, we can only see the first title slide.
That's what I thought. But I've shared my screen, so
no.
It should. And I do.
One second. Let Prithvi do it for you. Now we can see it. Go ahead.
Sorry.
Okay.
So this was the fantastic slide I was talking about.
Sorry, we couldn't see that.
Apologies. It's so this if you can see this now, the numbers tell us that it's not one specialty, or it's everybody, regardless of the percentage. There's not much variation, and this is itself the reason why all of us need to take a bit of care of our own selves before we go and help our patients. So it happened to me sometime at the end of my post-graduation. I became absolutely annoying to my own self and to people around me, and I used unhealthy coping mechanisms. Number 1 was this, our favorite national drink, but the second one was Netflix. And with that, I used a lot of popcorn and soft porn. The combination of this became absolutely deadly. I thought I was de-stressing, but actually I was digging a grave for myself deeper than I could handle. Then I was told to get help, got some help. They cracked it down, broke it down into small pieces. And then they said that maybe you're not so bad after all. Maybe you're just burnt out. And I wanted to understand what this is. I started reading more about it. Then, as you can see, some of the names are quite popular amongst the people who've done this study. Got a bit of understanding, a deeper understanding, got it published in a reasonable journal. And then I went through my own journey, deeper, like inside my own head, and went through a proper 10-day absolute silence course, which is very, very difficult for me. I learned a few things about myself. I can't say I came back wise like a Buddha, but at least one tiny step towards that. And then I was also told to go through this very deep therapy, understand personalities and why we do certain things and self-destruct. And I realized that it probably runs in families and in cultures. All of that learning, and I think I've become 5% better than what I was 5 years ago. So maybe that's how much you can actually do when it comes to deep learning. Came back and again started doing what we love doing, intellectual self promotion by doing a lot of unnecessary journal publications, which is what we did here again. Published something, felt very proud of ourselves, and we said enough is enough. Let's publish something a bit more meaningful this time. And this time we said action. Everybody knows everybody's burnt out. We like to cry about it. We like to publish stuff about it. But we said now action. Because we've grown in stature now, we understand that we really want to make difference. So this study was very, very interesting because we actually got solutions here. We used those solutions in a national WHO meeting to say this is published now and these are solutions. We need to make changes. So in the last white paper with the WHO for overcrowding in emergency medicine departments, the results were pushed through. Hopefully in a few years, it may just be some policy. So we felt that, yes, we are making change. And then we said one final nail in the coffin of rubbish literature. William and I got a chance to be a guest editors here, and we put strong words saying, let's not just publish for the sake of publishing, going on doing the same research 10 times and saying we've done something. We know there's a problem. If you want to do research, talk about solutions, talk about what you've done. Don't give advice. So we said that's going to be our motto from now onwards. Not tell everybody, take care of yourself. That's absolute rubbish. What have we done? The first we did was understanding the problem. We are not psychiatrists. In fact, the entire team has just 2 psychiatrists and 1 psychologist. And this was all deliberate as a part of a strategy, which we learned over our 7 years journey. So what is the definition of this burnout? Emotional exhaustion. And I can only tell you what I went through. Basically, patients were dying left, right, and center. I actually had absolutely nothing, no reaction to that, including my own aunt. When she was so critical, I just said, okay. My family is like, what in my okay? Is that your response? She's been like a mother to you. So that's emotional exhaustion for you. Depersonalization, patients coming in with broken arms, probably drunk, bad head injury. And I'll be like, okay, you're getting some pain. Okay, why don't you drink some more alcohol? It'll solve your pain. And people are like, what's wrong with you? We thought you were a kind guy who would offer chairs to patients in a busy emergency department. Why have you become so evil? Basically, I was just getting a bit depersonalized. And low personal accomplishment. So somebody is like, oh, Murthu, man, you managed this really well. So quick decisions. How do you do all of this? I'll be like, anyway, it's useless. ICU is going to complain about me. Medicine's going to, I don't think it matters. Anyway, they'll get the sweets. I mean, what kind of answers were those? I don't know what I was saying. Thankfully, there's a term for it. It's called low personal accomplishment. That's where I was. So combination of all this was what they formally call burnout. But like we said earlier, today is not about cribbing and saying how everybody got burnt out. Everybody did. What are we going to do about it? Understanding the factors is key. So compiling a few studies, we've jotted down some numbers. Most of them are sort of unique to emergency medicine and critical care, because that's what I understand best. So first thing is lack of awareness. Most of us just think this is just me going mad, or I'm a bad guy, you're a bad woman, all of that rubbish. But it's just lack of awareness that it can also be a sort of syndromic in its nature. Sleep-wake cycle disruption, the shift nature of work can itself do that to us. High rates of mortality inherent in the Indian system. Poor exercise and diet, which we like advising people, but we don't like following ourselves. Fear of exposure to infections. I think this is not so much. This is sounding very Western. Like worry about somebody sneezing and everybody will go running. Here, I don't think that matters so much. Substance abuse. You'll see so many people from within the Johns community itself opening up and saying that this is a problem. Within us, within a group of us, it is a problem, which is fantastic to at least accept it. And then fear of lawsuits, not so much, maybe in a safe, sort of sensible medical college like St. John's. But medical errors, yes, the fear of getting reprimanded. All of this combines and creates burnout. So awareness, I'm happy that the Alumni Association is actually putting a topic like this in such a solidly organized CME. You put a sort of semi-solid topic like wellness there, which is already a big step towards burnout. Now, helplines. So there are some, God knows how many helplines. We researched all of this over the last 7 years in multiple committee meetings. All of this is available. The question is, do people actually take this? And when you actually call them, is it really functional? The answer is a sorry no, because when you're burnt out, the last thing you're going to do is go Google, find some number and call them. It just doesn't happen. So that's why we moved our strategy. Like I remind everybody, we're not some mental health organization. We're a well-being team. And we've moved towards doing our things our own way, rather than begging some association to sort of bring changes. So we formed a company and we paid all of the expenditures by ourselves, and we said, let's do the fun thing. We can't treat burnout because we're not trained, but we can prevent it. Let's bring back a bit of a spark, like they say, bring back a smile to that beautiful face of Linda. She was 2005 batch, and she said one of the things she loved the most as a child was playing with dough. And during COVID, when we were all getting completely frustrated, we said, okay, Linda, you like playing with dough. You've made some fantastic soaps. She's a dermatologist and gifting them to us for free. Let's make a business out of it. So you enjoy your hobby. We do the selling for you. At the same time, we sell something meaningful, which is actually healthy, sulfate-free soaps. We tried selling them, and as a business strategy, I must be honest, this was a massive, massive failure. Lost truckloads of money, but it was okay. At least somebody got happy. Linda felt inspired. Then we came on with protein bars, different from the standard protein bars, which are basically lots of fake stuff. And again, at this one, we were wiser. And as a business strategy, even this was a massive, massive failure. So we said, okay, we're not good at this. We'll go into events. We went, attacked the government health facility in Bombay and got 2 doctors to do a painting workshop for people in the middle of a shift. No point telling people come at 7 o'clock after you go home for your own well-being. Doesn't work. During the shift, we figure out methods. Everybody comes together, learns a new hobby. All of these hobbies are taught by doctors and nurses, 2 doctors and nurses. An open mic, you can see lots of people enjoy just coming and reciting a poem. So many of them have forgotten that they'd written poems. Similarly, a guitar workshop was done in Mumbai. And the key again, if you notice closely, it's 2 p.m. to 4 p.m., the time and venue. It's inside the hospital. We had to do all the boring work of going to the dean, getting letters saying, no point keeping it on a Saturday. It's not fair to the residents. We do it during work hours. We figure out how to do it. Facilitators are all doctors. This is not a talent show where I come and perform and you clap for me. It's me getting each one in the hall to touch a guitar, play 1 chord in each of these stations. Similarly, a photography, I don't know if anybody knows this legend. He's 2003 batch. He was a cardiothoracic surgeon. And in this event, he went on amongst many other doctors from across India to describe their photographs and beautiful detailing. I was like, wow. Doctors actually think that much before clicking a photograph. And it's fantastic. And the philosophy they brought with their photography is fantastic. We then did a picnic. We partnered with a resort in India, in Bangalore. We have 3 other partners in different parts of India. And this is to get doctors who don't know each other to spend time together. The advantage, if you know each other, you're going to crib about workplace. I got this fellowship in this. Nobody cares how many degrees you have. This is just few doctors told each of them is supposed to teach the other something that's not medical. And as you can see here, this is Randall from 2005 batch. And beside him is a complete stranger to St. John's who came for the meeting just because she heard it from another friend's profile. And they taught each other fantastic things, which could also mean barbecue. Now coming to the final bit of what we need, because I was told 10 minutes only, and I want to stick across 20 seconds, how you can help us grow as an organization. First is just follow the Instagram page. And I believe that once this talk is over, nobody's going to do it. So I'm going to pause for 10 seconds for you to actually take your phones, log into Instagram and follow. Attend these events. These events are meant for people to perform and not usual performers. People who don't usually perform, it's meant for them. And do spread the code blue word. We are now turning into a not-for-profit. The paperwork is on, and it'll be fantastic if the word could be spread via all methods. Best method is word of mouth. Cheapest, deepest. Thank you very much. Thank you for your patient listening. I'd like to then ask Dr. Anjali to see if she wants to invite Vaishnavi, who will probably speak something which is more in-depth rather than just a fun hi and bye from me. Thank you.
Thanks, Murtaza. You can, I think it would be good if you introduced Vaishnavi, please.
Fantastic. Yes, yes, thank you. I was actually expecting an applause, but I think you can't unmute the
You
mic.
can't applause, you can applaud yourself.
Okay,
Thanks.
I've done that. I've done that. It's a virtual pat on the back. That's what they say we should do. So next on, for the next 10 minutes is Vaishnavi.
Somebody sent you a virtual clap, so you can now introduce Dr. Vaishnavi.
That's made my day. That's what I needed. Okay, super. So Vaishnavi actually dared to come for a random picnic which said soft skills and well-being for doctors in a picnic because Dr. Anthony Robert, he said she works with him and he said, go for this. It has to be good. And she came and she just realized she had forgotten all her hobbies, revived some of them in this picnic, and then worked with the entire team for 6 years and has gone on to become the director. She's a pediatrician by training, and I'd like her to now tell us some real stories of what she has experienced and what she has learned. Thank you very much. On to you, Vaishnavi. I'm going to stop sharing my screen.
Yeah. Thank you so much for that, Muthu. Are you guys able to hear me?
Yes, yes.
Yeah, we
Okay,
can hear
great.
you.
Okay, let me just try sharing the screen. Entire screen. I'm unable to find that. Could one of you share it
Yeah,
instead? I'll share it in the
if you
WhatsApp
just give
group.
us a second, we'll share the screen for you.
Yeah, let me. Okay. Yeah. Okay, great. Thanks. Okay. Hi. So, a small correction to what Murthu said. Dr. Robert actually told me about an open mic poetry meet. So, I do write poems. So, he said, why don't you try this? And he just forwarded that bit to me. And I took part and I met a group of lovely individuals. Everybody was stressed, but, we found solace in reciting poetry and we had a nice open mic virtually. This was all during COVID time. And then I happened to go for the picnic and then got so involved with this organization. So I would strongly suggest that you all also participate and take part and follow us on Instagram as well as on in real events, because it definitely makes a big difference, because we're all stressed, we're all getting burnt out, and so having like a group of like-minded individuals really does help to take the stress off, and you can revive your hobbies, you rekindle all your passions, and it really does make a big difference to you. Could you go to the next slide, please? So, yeah, I'm going to speak on sleep hygiene for sleepless medicos. How many of you relate to this slide where you feel like so sleepy and lethargic, sluggish during the day? At night, you're like, I'm so tired, but then you're like wide awake, right? Okay, I can control it. Great, thanks. So, and how many of you have trouble falling asleep? Sure, like a raise hands. Okay, Murtu's raised. Anybody else has trouble falling asleep? Ah, okay, great. Yeah, there are others. So I was definitely in this category. And again, I related to this meme a lot because I would lie awake in bed until like early hours, until like 5 a.m. And then just before, like an hour before I'm supposed to get up is when I would fall asleep. So I self-prescribed, sleeping medicines, and then I had to rely on melatonin and all of that. But still, during the day, I would still be groggy, sluggish. I would really require coffee to get me through the day. So then I decided enough is enough. I can't keep taking these forever. And I made some lifestyle changes. And that has helped me a lot. And that is what I want to share with you today. So it's very easy for me to say, oh, get 8 hours of sleep, or, eat healthy, all of that. But we know that practically it's very difficult since we are doctors. We have either 24-hour shifts or night shifts and, varying shifts. So I'm just going to give you practical advice that will help you, like before your shift, during your shift, what you have to do and how to unwind after your shift. So before your shift, make sure that when you wake up in the morning, you expose yourself to sunlight for at least 5 minutes. Nobody is asking you to stay for a full hour outside, which may be practically difficult, but just even 5 minutes and get moving. Like just go for a short walk, 5 minute or 10-minute walk, do some stretches or some light exercise. All of that will definitely help to set your circadian rhythm well. And yes, so talking about moving again, you don't need to enroll in a gym or do a 45-minute workout, intense workout. Just dance to fast music in your room just before you get ready. Even that does help to boost your, adrenaline and cortisol, and you will feel much more active and ready to take on the day. And have a cold shower in the morning. That does help again to increase your alertness. It increases dopamine as well. And at night, just before you shower, just before you sleep, take a warm shower, which will help you to again relax. And during the shift, so when you have night shift, you're supposed to stay alert and awake. So you have to use light exposure strategically. Okay, so during the night shifts, you expose yourself to bright light to stay alert, and you can splash your face with water whenever you're feeling sleepy. Take a quick walk, deep breaths, listen to some fast music again. Like I used to do that in my NICU shifts. We had 32 hours straight shifts. And just when writing, because you're constantly on the run, attending deliveries and then tending to sick babies, and you have to write the drug chart for the next day. So I remember listening to like music when I was writing the drug charts. That would help me keep me alert, because otherwise you're just so tired you want to just crash. So you could try listening to some music and take short naps. If you can take a break, if you can get a colleague to cover you for a few minutes, then even short power naps does help to make you feel more alert. Longer naps though will make you feel groggy. So try to avoid those. And after the shift again, it's you have a busy shift, you're so stressed, you're so like, oh my god, what happened to this patient, do I have to follow up the report of that patient? So after you've given handover, you come back and just you have to engage in something that will help you to calm down, okay, from a stressful shift. So engage particularly in calming activities that tells your body it is time to sleep. So you could read, you could take a warm bath, or practice some relaxation techniques. Even just a 5-minute meditation or deep breathing exercise will help. And try to put yourself in nature, a nearby park or garden, or some area where a lot of plants are present definitely does help to calm you down. And interestingly, now this concept of grounding is very popular. So this is basically just walking barefoot on earth. It could be either the beach or just a patch of land. Just it helps to actually detox your body. It helps to get rid of negative emotions. So just walk barefoot if possible for 5 minutes. And if you're a mouth breather, then consider taping your mouth shut. You get this micropore kind of strips. So you can just tape your mouth, but make sure that you don't have severe sleep apnea or very bad snoring. But in general, a lot of people do find relief when they tape their mouth, when they are mouth breathers, especially because some of them have a very disturbed sleep, but they sleep better after taping the mouth. And another thing, like I said, journal out your thoughts or worries before hitting the bed, because if you're constantly going to be thinking about how your shift went or about what all you have to do for tomorrow, then it's going to be hard. Your mind is just going to be overactive and in drive. So again, just write down a to-do list for tomorrow or whatever else you need to get out of your head. Please do get it out. And minimize your exposure to screens. This is something that we are all guilty of, including me. So to tell you a practical example, when I was having like these 24-hour shifts, and I would take my laptop, I would finish like OP at 8:30 or 9 only. And then I'll be so tired. I'll be like actually quite ready to fall asleep. But then I'll be like, oh, I brought my laptop. Let me just treat myself. I saw so many patients. I'll just watch one episode of this series. And all of us know that one episode doesn't stop with one episode. So although I was so tired and physically drained, I would keep watching, and sometimes it would go on till 1 a.m. So somebody who's supposed to fall asleep by 11 or 12 at the most would actually be watching until 1 a.m., then switch it off, then still be thinking about the series in my mind and still be awake. So then I made a habit of not taking my laptop to work on the days that I have night shift. And then I would instead take a book, and I would read a book, and I would fall asleep much faster. So we have to make some changes in our environment, which will enable us to practice this, because it's so hard. I know it's like whatever content that we see is just so addictive. It's making us binge on that again and again. So try keeping your phone away from your bed. If it's right next to you and if you're trying to fall asleep, 5-10 minutes you'll try. Then you're just going to take and start scrolling either on Instagram or watch a YouTube short. So instead of that, keep your phone actually physically away from your bedside, like on a desk or somewhere far where you'll have to actually get up and go and take it. So doing small changes like this will help, because we all know the blue light does disturb our melatonin and it makes it very difficult to fall asleep. So, okay, you may not be able to like sleep during your shift, or you may have trouble falling asleep. So what can we do for that? So here you have something called non-sleep deep relaxation. So in this basically tries to provide similar benefits to sleep, like it reduces your stress and increases your mental clarity and physical rejuvenation, but you don't completely fall asleep. So some of the things that, so they basically help, like I said, people who have difficulty falling asleep. And examples will be meditation, which engages in mindful practices. It focuses on deep relaxation and calming the mind. Sorry, this is not getting seen fully. But the others is progressive muscle relaxation, where basically from the tip of your toes until your head. So each part, your calves, then your knees, and then your thighs, like that, part by part, you have to think, you have to clench and release it. Okay. And of course, yoga, pranayama, or deep breathing, and anulom vilom. So that's alternate nostril breathing. So just watching a video on YouTube will help to guide you to do this. And you could do this when you have trouble falling asleep. Yeah. And then what about coffee? So this is something that a lot of us do rely on to get through the day. So ideal time to have coffee is actually 90 to 120 minutes, which is basically like an hour and a half to 2 hours after waking up. Because as soon as you wake up, when you have coffee, you will invariably start craving it again and have want to have multiple cups throughout the day. So avoid it in the afternoon and evening because it has a half-life of about 5 hours. So if you drink it at say 5 p.m. or 6 p.m., at 10 p.m. when you're supposed to fall asleep, still you have half the amount of coffee still in your bloodstream, which means even if you're physically tired, you're not going to fall into a deep sleep simply because of this. So you can replace it with something like hot herbal tea or lemon water, hot lemon water, etc. So coffee ideal time will be say around 8 or 9ish in the morning, and maybe a cup at so 1 o'clock or so. I think my screen sharing has gone.
Is it because time's up? I don't know. Oh no.
Okay. Okay. And yeah, alcohol, please do try to avoid if you want to fall into a deep sleep, because it does disturb your sleep pattern. You'll have a very irregular kind of sleep. And seek professional help if required. If it's still persisting despite all this, consult a sleep specialist. And see, shift work does disturb our normal sleep pattern, so adjusting to these changes will take time, but being consistent and patient with these strategies, it will improve the quality of sleep for us. And since we are in the healthcare profession, every decision we make has to be good. It has to be when we are alert and fully coherent. Like taking a decision when we are half asleep or very groggy can result in harm to the patient. So please do practice these strategies, and ensure that you have a better sleep cycle. Some resources, these are clickable actually, so I'll be happy to share the presentation so you guys can use it. And so you have these meditation musics, which is 5 minutes, 10 minutes. You don't need an hour or 45 minutes of some intense thing. You can just do 5 or 10 minutes and that will still help you. And there's an app called Let's Meditate on Google Play Store that again has meditation for ranging from 5 minutes up to 40 minutes. So you can choose what you want. And your hour is something that helps monitor time, because a lot of us are, addicted to social media, and it's taking a toll on our health, on our personal lives, and time spent with people we love. So this will tell you how much time you're spending, and it will help you to cut down on that. And you have app block options as well. So this was me. I think the time is up. So thank you so much for a patient hearing. And I strongly encourage you all to join the Code Blue movement, because we need healers for healers. We need to heal ourselves first, and holistic wellness is just so important. Thank you so much.
Thank you, Dr. Vaishnavi, and thank you, Murtaza. We will move on to the next topic by Dr. Satvik Pai. So while we hope that you don't have any medical legal issues, it's always good to know what you can do, especially in your area of practice. So Satvik is an orthopedician, but he is also a lead in a legal consulting firm, which is Help Firm. So Satvik, take it away, please.
Hi, thanks, Anjali. Is my screen and my audio good?
Your screen is, yes, your screen is seen and you are audible.
Yeah. Okay. So I'll dive straight into the topic. So basically, today we are going to be discussing the handling of common medical legal problems in rural practice. About myself, so I'm an assistant professor at PS Medical College in Orthopedics Department in Bangalore, and also I run a medical legal firm that helps medical professionals deal with medical legal issues. So I'm sure the first question people may have is why bother? So the law is a pretty boring topic, something that we are not too familiar with, and a common thinking of people is that why bother about these issues if I'm not facing it right now. So let the problem happen, and then we can maybe find the solution. So I'll just get into that before I get into the actual topic. So this is a quote. It says, "No physician, however conscientious or careful, can tell what day or hour he may not be the object of some undeserved attack, malicious accusation, blackmail, or suit for damages." So this may sound like something that's in our newspapers these days, hearing all the incidents of violence against doctors, all the lawsuits that are happening. But this was actually published in the Journal of American Medical Association in 1892. So many centuries ago, in fact, and still this was a problem even then. So definitely a factor then, even a factor now. And we'll just get into what we should be doing to avoid this. So the current situation, the data from the US at least, is that at least one out of every 2 doctors have...
Sorry, Satvik, can I interrupt? You have control of the presentation.
Yes.
Yeah, okay.
Yeah. So in the US, more than half of the doctors have at least one lawsuit against them, and among surgeons, that's more than 80%. In India, unfortunately, we don't have the exact data like that, but we do know that it's increasing 110% each year. So the number of lawsuits against doctors increasing 110% each year on year. If you see the consumer court cases, more than 12% of the cases are all just medical legal cases. Okay, so there's no doubt that we are already on the highway to hell. Whatever we do, we are definitely set on this path on how healthcare and how health litigation is going towards. So rather than discuss about topics which may be out of our individual control, about how we decrease this as a whole, I'm going to speak specifically about things that we should be doing as an individual, how you should be protecting yourself. Okay. So the other question is why now? Like I said, common thing that I know people will have in their mind is let's bother about this once there is an actual problem. So I'll just give you a situation. So if you are entering into a battlefield, so when do you think you should be wearing that bulletproof vest? Do you think you should be wearing it before you enter into the battlefield, or do you think you should be wearing it after you're in the battlefield, you are right in front of your enemy and the enemy is firing bullets, right? So you want that bulletproof vest even before you enter into the battlefield. So getting to know about these medical legal aspects is like that bulletproof vest, and you should be aware of this before you even enter into that field, rather than wait for a case that has happened, rather than wait for a problem that's happened and then try and solve it. Most of the times that's almost too late, right? So I'm not going into specific laws. I know that will bore everyone here. So I'm just going to talk about 5 real life case scenarios. This has happened. Again, I've picked case scenarios which are more common in the rural setup. So these are common scenarios. These are not something extremely rare, some rare situation, how to deal with it. I'm not going to go into that. I'm going to talk about 5 common case scenarios that you may face, no matter what your specialty is, no matter what your field of work is in healthcare. These are probably situations that you might face. Okay, so
Dr. Sathwik, sorry to interrupt. Your slides are not visible. Could you just put on slideshow? Yeah. Yes, I think and slideshow.
Yeah.
Okay. Thank you.
Is it visible now? Hello?
Yes, it is.
Are my slides
Yes,
visible? Yeah. So how I'm going to keep this is it's an interactive thing. So anyone can interrupt me at any time. Just give me their inputs on what they would do in the case. For a shortage of time, maybe just one answer per case scenario, but anyone's free to just pop in and say what they think. Okay, so this is the first case scenario. A patient comes to the OPD with complaints of vague complaints of abdominal pain. So the patient was advised antacids by the doctor and basically sent home after that. So the next day, the patient comes back with persistent abdominal pain. So now the doctors again examined the patient, found some amount of tenderness in the abdomen, I guess. So he's advised an ultrasound of the abdomen and pelvis. Now the patient doesn't get the ultrasound done, whatever their reasons, financial or whatever, but the patient doesn't get it done, doesn't get admitted, goes home. Okay. So 2 days later, the patient has basically had an appendix rupture and passed away. Now here, the doctor's done their job. He's basically examined the patient, suspected an appendicitis, advised for an ultrasound. Patient has not listened to this doctor basically and gone away, right? So seems like there's no fault of the doctor here. But then the patient family claims that the doctor didn't advise to get admitted. Again, this is a real case that has happened. Patient says the attenders of the patient basically saying the doctor just told them that everything is fine and send them away. Okay. And so now the question is, who is the court going to believe? The patient saying one story and the doctor saying another story, right? Now we may be thinking from the doctor's point of view here that there's nothing wrong. The doctor's done absolutely followed what the normal protocol would be. And this is the patient who has not listened to the doctor. And still, why is the doctor facing this litigation? But I'd like you to think from the point of view of the judge. All they are seeing is 2 different conflicting opinions here, one from the doctor and one from the patient. Okay, so now who is the judge going to believe? Even if you remove all of their preconceived notions, all of that, even if you were in their place, I think it would be difficult to decide who you're going to believe at that point. And that brings me to the importance of preserving medical records. Okay, so the common thinking is that it's the patient's job to kind of bring back all the medical records, but no, according to the law, it's a responsibility of the healthcare professional also to maintain all healthcare records. Okay, so all healthcare records have to be maintained for a minimum of 3 years, and that includes your OPD records. So if you're seeing a patient in OPD, if you're seeing a patient in the ER, you still have to maintain medical records of that. Any medical MLC case that is registered, RTAs, etc., whichever is an MLC case registered, has to be preserved for 10 years. And if there is an ongoing legal battle, or you think that there may be an ongoing legal litigation in the future on that case, definitely preserve that indefinitely. The reason why it's kept 3 years is 3 years is the statute of limitations for a person to file a case after a complication has occurred. So that's the minimum that you need to keep up. But again, I would like to specify two particular things that we miss often. Is maybe inpatient records most of the hospitals keep, most of the establishments keep, but OPD records, that's an important one, and your medical certificates issued. So it doesn't matter whether it's just a leave certificate, a fitness certificate. It is compulsory that the medical professional has to keep a record of those. So if they are ever in dispute, it may not even be a dispute about whether that patient was sick, whether your diagnosis were right. It may be a completely different issue of what the patient has done later on while they are on leave, while they are, got back fitness, joined the workforce, and then some problem happens entirely by the patient. But if your medical certificate comes under, is a part of it, then you basically have to present records of it. So very important that you have all of these records. And like I said, this case, basically at the end of the day, the case that I just told you, basically at the end of the day, the judge is going to decide purely based on what is there on paper. He's not going to choose, okay, the patient or the doctor, who am I going to listen to? He's going to decide what's on paper. And in this case, I just like to tell you, so it may seem like, okay, what's on paper is also pretty straightforward. But the reason I put up this case was, so the patient, basically what they did was they presented the first OPD consultation, right? Where the patient has just written antacids and sent the patient home. And they didn't present the second one, where they've advised admission, where they've advised an ultrasound. They have not presented that one, right? So there's a completely different picture presented to the court, is that all that the doctor did was advise antacids and send them home, right? So instead of relying on the patient for that, that is why it is important that you preserve your own medical records and keep a track of it. Okay, so that's the first case. So coming to another case scenario, so a patient comes with a history of a road traffic accident. The patient vitals are normal. He's completely, the BP, everything is completely normal, no severe bleeding, but he's complaining of pain in the knee. So you obviously examine the knee and you advise an X-ray. Now, patient also gives a history of loss of consciousness and vomiting. Okay, so there is a head injury there. So now the question I would put to you is, say you're working in a rural setup, X-ray facility is available, you're going to get the knee X-ray done, but there's no CT facility available. So there's no CT brain that you're able to do. So now the question would be, so should you treat this patient or refer this patient to a higher center? Questions open to anyone who wants to answer. There's obviously no right or wrong answer, but basically, what would you do in this situation? Patient is conscious. There's no, he's completely oriented, speaking to you or everything. So what would you do in this situation?
You can unmute yourself and answer the question.
Anyone?
I will refer the patient because of the history of loss of consciousness and vomiting.
Okay, so you're suspecting some form of bleed. So you feel a CT is necessary, absolutely necessary?
Yes, it is up to them to do or not, but I will advise and I will also refer because something may be developing in the brain all the time.
Okay. So fair enough. That's definitely what you should be doing, is that if there is definitely a history of loss of consciousness and vomiting, then even though the patient is vitally stable, you should be getting a CT brain done. So, but the trick would be that in most of the times when we're talking practically, the attenders are insisting that you do the treatment here. The attenders are saying, just treat, he's fine, don't worry about the head injury, he's speaking, all of that. He has a knee, he's complaining of pain in the knee, you please treat us for what we have come. Okay, so this is what they are saying. So now what would you do? To the same person who answered that, again, your first answer was absolutely right, but this is a common thing, right? So the attenders are insisting that, no, you do the treatment here, we're not going all the way to another city or a place which has CT, they're not ready to go. So they're saying that they're insisting that you do the treatment there. And then what do you do?
Okay, I have come across such scenarios where they say you do, and we are not able to go such to higher places. So I take a high risk consent and I say that this is being told to them, and they are not able to go due to these reasons. And should anything happen, the patient and family is responsible. Or if they need any time reference further, should the patient deteriorates over time, they will be ready to go to higher place.
Okay, so that's definitely a good practice. Definitely a good practice. That would be exactly what I would have recommended in the same situation. So definitely a good practice that you're doing. So we just come to the question of how do courts look at different levels of care? Okay, so is the court going to look at you treating a patient in a rural setup with maybe limited amount of resources available to you, the same as how the court is going to look at, say, a patient or a doctor who's treating in a corporate hospital in a metro city like Bangalore, which has all the specialists, all the facilities available to them? So is the court going to look at both the same? So how I would say it is, definitely courts are aware that there is a difference in both the situations, and they are not going to look at it the same way. Okay, so they are going to take into consideration what facilities you have available there, what kind of medical support and infrastructure support you have available there. They are definitely going to look at this factor, and how they have decided cases as well in the situations of mainly rural practice or maybe government setups which have limited amount of resources, is they have definitely acknowledged that, and acknowledged that some resources may not be available, and the treatment expectations in those situations are different from what it would be in a high referral center. Okay, but let me point out here that the law though is the same. Okay, now this may be a consideration that judges would take into effect when they are deciding, but you must be aware that there is no separate laws there for rural doctors. There's no separate laws there for city doctors or corporate doctors. At the end of the day, the law is the same, and the expectation out of the doctor as per the law is actually the same. Now your infrastructure may differ. Now what your facilities available there may differ, but what that expectation of expertise is from you is actually the same. So they are going to decide based on what a competent doctor would do in that same situation. So whether you are in a rural setting or whether you are in an urban setting with all facilities available, the expectation of knowledge and practice and the decision making that you are going to enforce expected is the same. Okay, so if you are an obstetrician in a rural setup, the expectation from you in terms of your decision making is the same as, in terms of your skill, is the same as what would be expected in terms of a city doctor or like I said, a person in a corporate hospital. Now the infrastructure considerations may be different, but remember that the level of expertise required out of you is actually the same as per the law. So they are not going to say, okay, rural doctor, city doctor. They are going to say an obstetrician, qualified obstetrician, this is the expectation. Obstetrician with this many years of experience, what would another obstetrician with this many years of experience do with the same facilities provided to them? But it is not going to be a lesser standard of care accepted that, okay, this is a patient who's in the rural setup, or this is a patient who's paying only this much, this is a poor patient, this is a patient who is going to accept anything in the rural setup treatment. No, the value of life put there would be the same. The standard of decision making required out of you would be the same actually. Okay, so that's an important point to remember. So coming to referrals, is it okay to refer? Yes, definitely it is fine to refer. You cannot treat everything just because based on your own skill. You require the infrastructure along with it. So it is completely okay to refer. If you always have a doubt of whether you should be referring or treating it, definitely if there is a doubt, treat it. Refer it. So if there's always a doubt, just refer it. If you're confident of treating it, you're confident that you're able to handle all of the things there, then you can go ahead and treat it. Now the question comes of emergencies. Okay, so now a patient comes in, already vitals are not stable. So what do you do in this situation? I would like to tell you the law sees elective cases completely differently to how it sees emergency cases. Okay, so in electives, yes, your allowed to make your decisions. You are allowed to refer if you feel that is better, even though you may or may not be able to, handle it. But if you have a doubt, always better to refer. The law is going to support you in that you've taken the more cautious approach and refer the patient. That will definitely come in your favor. But now what when it comes to emergencies? So in emergency situations, let me tell you, you have a duty to treat. As per the law, you have to basically treat that patient. You cannot purely say, okay, this is not my case, I'm not going to deal with it. And this applies even to, say, I'm an orthopedician, I have no expertise in dealing with maybe a patient who comes in with, like I said, a road traffic accident, not a road traffic accident, but say a head injury, something. So patients come, I am not a neurosurgeon, I have no idea how to manage it, but still I am expected to deliver a standard of care expected out of an MBBS doctor. So I need to at least be able to stabilize the patient and then refer them out. So the recommendation would be that you can still refer out emergencies as well, but do some amount of basic treatment, if not anything. So if you're not sure of what treatment that needs to be given, at least make sure you're documenting whatever history, examination findings you're there, whatever IV fluid was started, whatever basic treatment, if there's an MI, what medication you have started, and then you have referred that patient out. Obviously, you can't continue the treatment of care there if you don't have a cardiologist or you don't have the facilities to treat it, but make sure you're doing some amount of basic care and then treating that patient out. How do you refer? So ideal situation would be that you document, like I said, what you've seen, what that patient history, even if it's just a history and examination, make sure you're documenting that. Even if you're just referring out that patient, even if you have not, not even started an IV line, you're just not even given a single medication, and you're literally just seen the patient, said, okay, this is definitely requiring higher treatment, send the patient away immediately. Now, you might have the good intention that why waste any amount of time, let the patient be out as soon as possible to the higher center where they're going to get the treatment. But I would definitely recommend put in a documentation, even if it's just the history and examination and the fact that you've referred them out, put it in writing, make sure that, it's there in writing. If you're referring, ideally, like I said, it's better if you specifically to which place you're referring. If you have had the time to have spoken to someone there, mention which place you're referring them to, which doctor you've spoken there to, and then you're referring them out. If your facility allows for it, if you all are arranging for an ambulance or some form of transport there, that is even better. Again, mention even that if your hospital is doing it. If you're not able to do it, there's no definitely a compulsion that you need to be providing an ambulance. But whatever you have done for that referral, do as much as you can. I understand practical difficulties of, if you're busy, you can't sit and do this for every patient, or there may be other constraints there. But whatever is done, definitely put it in paper and then refer that patient out. Because like I said, if you don't, then it just leaves an entire gray area of what might have happened. Now, you might be thinking that, okay, I've not even treated the patient, but you have no idea how the patient or the lawyer is going to turn this around. So whatever it is that has happened, even if you have seen the patient literally for 2 minutes and refer them out, put it on paper and then send them out. Okay. So that was what I would say about referring. So the next case scenario is a 50-year-old gentleman has come with complaints of chest pain. So the ECG is done, shows an acute MI. Patient suddenly goes into ventricular fibrillation, flatlines. Okay. So you have done CPR, you're not able to revive the patient. Okay. So now the attenders are getting agitated. There's a mob collecting outside and they're basically beginning to get aggressive. Okay. So this may be a situation. Maybe a situation, no matter what the condition is, the moment a patient starts deteriorating, you kind of have the situation where, there's slowly agitation among the attenders, more number are collecting, all of it. This happens even in cities. It's not just in rural practice, but maybe in rural practice, the burden feels a little more because there's less amount of support there with you. Okay, so what do you do in this situation? Again, the question is open to anyone there. So what do you think you should do? Again, medically, like I said, acute MI recognized, CPR done. You have done the best you can do. So I'm not talking about what you would do for the patient. I'm talking about what you would do in this situation. A mob is slowly collecting, they're beginning to get agitated and aggressive. So what do you do as the doctor there? Anyone? they can just share whatever's happened in their situation if they face something similar to it. May not have been a mob, may have been just a few attenders also, but getting aggressive, or if you've not faced that situation, it's definitely a good practice to think about what you would do in that situation. So what do you think you would do in your own setup, wherever you're working?
These are the common happenings happening in these rural areas. So we would inform the police station immediately and get security for ourselves and for the institution. And there would be a spokesperson to the attenders and the mob, whoever is there, but they'll be aggressive. They may not be able to even have a conversation with us. So first is the security. That's what I would say. Yeah.
Okay. Are you going to try and explain to the mob? Would you try and calm down the mob?
Yeah, definitely we will do that first. We will do that. Yeah.
Okay. So what are you going to speak? What are you going to tell them basically?
It's like what has happened. Like the events of this. Yeah, the patient came here and we have done what was possible from our part, and we have done the best, and that was what you gave the presentation of this patient. So we would explain to them. Yeah.
Okay. So we'll just come to the discussion on what you should do when patient or the attenders are basically potentially becoming violent. Okay. So there's two things. One is de-escalation of the situation, and the other thing is the safety precautions. But actually, it should be in the opposite order. So the first thing you should be doing, as the person definitely rightly said, is the safety point of view. Okay, the de-escalation comes later. First is your own safety. Okay, so absolutely that is the first and most important thing. Even if you don't know anything else, make sure that you are safe by yourself. Everything else can be accounted for, can be managed later, can be managed by others, but your own safety is definitely 100% the first most important thing. Okay, so how you should be ensuring safety is the first thing. The moment you find a situation which is getting out of hand, they are about to get agitated. You don't even wait for a situation where they're already violent. So the moment you feel this may be going towards that, is the first thing is call for backup. Okay, even before you speak to the attender, even before you speak to anyone, make sure you're calling for backup. Whether it's your seniors, whether it's your colleagues, whether it's administrative staff, make sure you're calling for backup. Do not try and be try and show that you can completely independently handle this. I'm not saying it's to prove anything to anyone, but we ourselves may feel like, okay, this is a situation I can handle. Definitely, if you are capable of it, you will be able to handle it. But even then, even if you are capable of handle it, make sure that there is backup there. There are seniors or colleagues or juniors, but make sure that there is some amount of support there for you in a potentially violent or agitated situation like this. Now, you should be counseling the patient, and you should be counseling the patient or the attenders. How you should be doing that is not in a bunch, not in a group. You must be taking only one or two patients. You must be speaking to them in a situation, in an area which is publicly accessible. You don't go into a room, completely close the door. Make sure, even if you're going and speaking to a room to ensure privacy, make sure that the patient, make sure that that there is access to it from outside. People can see if something happens, they're able to see it. Make sure that you have access immediately outward. So if you're, some of the things may be out of your control, but make sure that you have access to the door and that you are not cornered in that room. So this is just basics of how you make sure that, and these are things that you do for every patient. How you should be having this place where you can counsel them, how you should be having access is something that you need to think of in a normal situation, not when there is an agitated situation. At that time, you're not going to be able to think of all of these things. So these are things you should be thinking of for any patient, and it is going to come to help of you when a patient actually gets agitated. Next thing is security. So having staff there, either security staff or police there to help you out, and like I said, is safe surroundings. So make sure that you're not in a place where they have access to other sharp objects, or they have not brought in some weapons or something like that. Coming to de-escalation, so just general things of how you de-escalate a situation. One is make sure that you make the person feel respected. Now, it may be difficult in that situation. I understand that when someone is agitated, when someone is accusing you of something, though you are sure of you have done your best, you have absolutely given everything that you can do, and you have done nothing wrong medically, and a person is accusing you of something so grave, it is automatic for us to become defensive. Okay, it is just natural tendency for us to do that way. But at that point, we have to take a step back, realize that this is not personal. This is not a comment, though they are directly commenting on your medical abilities. It is not actually a comment on your medical abilities. It is them expressing their agitation. To try and see it from that point of view, of not taking it personally. That person now is basically agitated. I'm not even going to get into what they're saying is right or wrong. Most of the times they are wrong. We know what we have done medically, and we know what the medical situation is. So don't try and think of it that way. Is that, see, I have done this. I have absolutely done it right way. When they are showing aggression, realize that this is a patient just expressing their agitation, their frustration. Make sure that the person feels respected. Make another common ploy is to repeat what the person's concerns are. So just tell them that yes, you understand what they're saying, though you might completely, when I say, you might completely want to tell them that, see, it's absolutely the opposite. You might keep wanting to say that, this has happened, this is what I've done. So where is even the question or all of this? That is us explaining to them what has happened medically, which in most situations, yes, you must do that initially, but once they keep being agitated, keep repeating the same things, our ploy often is to keep saying the same things of, okay, this has happened, not realizing that we are talking about two different things, right? So one, you have already said what has happened medically. So now it's about de-escalating the situation, make sure that the other person feels hurt. That is what they're trying to get across. So you tell them, you treat them with respect. Even if they are wrong, you treat them with respect. Even if they're making false accusations, you treat them with respect. You repeat what the attender's concerns are. You mention that you understand what their concern is. Though you absolutely know that it doesn't matter because you've done what is medically right. You mention that you understand what that patient's concerns are. And when you tell them things, now you give them this belief that, okay, you have heard what they're saying. This is what has happened though. And now when you want something to happen further, make sure that you are being, again, respectful and being open and asking for open-ended questions. So a common example of that is, now say that example that I gave you, CPR is done, patients not being able to be revived basically. Now the attenders, you need them to decide whether they're going to take the body and go, or what they're going to do further. Would they be okay to, undergo an autopsy, all of this. So you basically need them to decide what they are going to do further. They are going on being agitated. You have already tried to explain to them. So now when you ask them of things like, okay, are you going to take the patient away? Are you okay for an autopsy? All of these things. Try and keep it as open-ended and not forceful as possible. I understand there's practical limitations of, okay, I need to go see the next patient. Okay, we need this bed, all of those things. But you are going to get your answer, but don't make it a forced question. So in the sense that don't tell them that, see, you know what, this has happened, patient has passed away, you take the body and go away, or we're going to call the police. Okay, don't put it across that way. Put it across in a sense that the same question can be asked in a sense like asking, okay, now see, I understand completely what has happened. I understand your fears. I understand your sorrow, but this is what has happened medically. Now, what do you want to do ahead? Now, the question may be, basically you're asking the same thing, is that what do you want to do ahead? What do you want to do? So they understand that, okay, do you want to take the body, or what do you want to do? It's the same question, it's the same options to the patient, but don't give that straight up, okay, take the body or go, or call the police. Don't give a question like that. Don't put it across like that. Instead, ask open-ended questions. I know all of this may sound very easy in a comfortable, calm situation, but all of this works only if you're practicing it on as many patients, as many normal, non-agitated patients, and then it would work in an agitated situation. Again, like I said, you might be 100% right. The reason for me telling you all of these things is not to say that you are wrong, not that you are wrong if you give them a direct question, not that if you're wrong if you just tell them what has happened, but this is points of de-escalation. If the situation escalates, no matter what you have done right medically, we don't want an escalated situation. Okay, so there's no benefit going to even, if they get violent, if you suffer any harm, it's not going to, be of any consolation to you that, okay, you know what, I did medically right. That job has been done. You've done your job to treat the patient. How you're handling with the attenders is a separate issue, and these things will help de-escalate that situation. What should you do when the patient or attenders become violent? Again, like I said, first thing is safety. Okay, absolutely. First thing is safety. Make an SOS call. Make sure there's someone there, support there. Should you try and, okay, so now say you're the support that has come in. Should you try and, stop them from being violent, try and, get into if they are being physical, try and protect your colleagues, all of that. Should you be having weapons, all of it? I would like to say all of this is not your job as a doctor. Okay, how you and rightly said, your job is not mob control. Okay, I am not an expert in mob control. I don't think any doctor is an expert in mob control, and that is not our job. Okay, so your job, even if you are in a limited resource setting, do not think that just because you're in a rural setting, I need to do every role. Okay, there are things that are out of your hands, and it is important to recognize when things are out of your hands. So managing the mob, that's not your job. That's not your job as a doctor. You need to be calling in support. You need to be calling in the security or the police. So they need to be handling that. It's not your job to go and handle 10 people, manage the mob. That's not what we are trained for. That's not our job. You should just be calling the police or whatever help, the security, to make sure that that is done. It is ideally the security's job to ensure that there is no mob collected, that not that many attenders are allowed inside the hospital premises, that it's only going to be 1 or 2 attenders that are allowed inside. And it's your job basically to speak to those attenders, not your job to even go and tell 30 people what has happened. They are not going to listen to it at that point. There is no point of you going and telling a mob, okay, see, this is an MI, this was there on the ECG, this was the correct treatment given. That is not going to work, right? So mob control is not your job. You do your job medically. You do try and de-escalate the situation with the 2 attenders who are there inside. Okay, how they handle the rest of the mob, how they go talk to the rest of the mob is up to them, or up to the police or the security to handle it, right? So the first thing you do, if there is ever a situation where you feel like you're not sure of things, is run. Don't be ashamed. Don't feel like this is you running away from the situation. This is purely you protecting yourself, which is the most important thing. Like I said, what happens with the body, what happens with the attenders who are agitated, what happens if they go to the lawyer, what happens if they go to the police, all of these things can be dealt with later on. But if, say, some concern happens to your own health, that cannot be reversed. So make sure that you are safe first. Absolutely no harm in even running away, making sure that you are in a safe place somewhere else. And even if you feel like your safety is under threat, don't even bother to do the things what I told you. Don't even bother to do that de-escalation. Don't even bother to tell them what has happened. If you feel there is a point where your safety is at threat, just get yourself into a safe situation, call someone and get other people to handle it. If your safety is under threat, first thing, get yourself into a safe place. Okay, what should we do? Like I said, I don't think these are situations which can be handled by one person, no matter how qualified or capable they are. That person who has been treating is the person who is most under fire, the person who may not be able to think clearly, may not be able to think calmly. I'm not saying it's wrong. They may just not be able to be in that calm situation because they are in that center of that storm. So at that point, just having someone else, even if they're a junior, in fact, is just better because they are not directly involved. This is again just basic normal human tendencies that if you are in that heat of that moment, you may not be able to think calmly, you may not be able to talk calmly, right? So just having someone so I think this is definitely a point where a team approach helps, and prevention is better than cure. Because of a shortage of time, I'm not going to go into detail about how you avoid violence. So that's an entire talk separately, but definitely again, just in general, prevention is better than cure. And like I said, many of these things you should be putting into practice on everyday patients. And that is going to help you when a patient becomes agitated, and not think that, okay, you know what, when an agitated patient comes, I'm going to try out this. That would obviously never work in that high pressure situation. Okay. So I'll just move a little bit faster here now for a shortage of time. So a patient has severe psoriasis. So you've advised methotrexate. Again, nothing wrong. Even if you're not a dermatologist, you've correctly diagnosed psoriasis, you have advised the patient methotrexate, or it may not even be psoriasis. So commonly rheumatoid arthritis may be. So you've advised them methotrexate. Patient has developed liver cirrhosis. Now who is responsible? Is the doctor responsible? Is the drug company responsible? Patients are going to say it's the doctor because they are the ones who have decided. They are the ones who have decided what drug. Even if they feel whatever the complication of the medicine is, they feel the doctor has decided that drug, so the doctor is responsible. So is the doctor responsible? I would like to say that the law obviously sees the point that there are risks worth taking. You have to weigh the pros and cons of anything. So the courts and the law basically sees that point, that they are not going to say every complication that is coming out of your decision is your responsibility. That is not how they're going to see it. So there's definitely legal protection for doctors when it comes to this. Now, what about if they're saying that it's a faulty drug? If they're saying that the quality of something was not good, okay? Now this comes often in surgical practice, often whenever you put any implant, whether it's a rod or a plate for orthopedicians, but a mesh for surgeons, or other any implant. The moment a complication happens, the first thing that they're going to do is say that you used a faulty implant, a substandard or poor quality implant. It may even happen with medicines, that maybe some complications happen with a medicine. The patient and attenders may be accusing that this is some, some poorly manufactured drug, poor quality drug that you have given, and that has caused it. So now what do you do? Are you are we responsible for the manufacturing? Are we, responsible for the quality of the implant that we have chosen? Here I would like to say that it's a simple thing, that we are not responsible for the quality as long as whatever implant or medicine that you've used has manufacturing approval. So it needs to have the necessary approval from the government agency. As long as that is there, that quality you are not responsible for. Okay, whatever implant it is, as long as for implants, medical devices. So it's basically in India that CDSCO approval. So as long as you're using something which has a CDSCO approval, you're not responsible for the quality point of view. Okay. But that is why I would like to say here that don't get into using things which don't have necessary CDSCO approval. Maybe there's financial constraints of the patient, not even your own hospital problem. I'm saying it's the patient who's saying, no, do it for me in this much amount of, cost, surgeries in this much, all of that. But don't get into using things which don't have CDSCO approval, because the moment you do something like that, then that liability of that quality comes on you. Okay, as long as you're using it from a standard company which has CDSCO approval, that liability is not on you. The moment you use something which is maybe locally manufactured, even if common thing in orthopedics, at least I can tell you, is there are Indian makes which do it, they do an exact copy of the good implants. They make it exactly like that at 1/10 the cost. And in terms of even quality, we may feel like it's exactly the same. But the moment you don't have that license, that CDSCO license is not that, you take that risk on yourself, which I definitely would not recommend. Okay. And the other thing would be, the moment there's a complication, this is a common thing we see, is don't try and hide it. Don't try and, push it under the rug. Try and, tell them that, okay, this is not happening. Try and give them a different reason. No, absolutely. It is okay to say that a complication has happened, even if it's because of the treatment. There's absolutely nothing wrong with it. Even document it. Okay. As long as if a complication has occurred, all you have to do is identify that complication and treat that correctly. As long as you're doing that, it's going to be a problem for you in terms of the law. So many times where cases have happened in the courts, even with our own clients, is that they have a complication, but they would have tried to avoid documenting complication. Sometimes they've even treated complication, but not documented it, because they don't want to put it in writing that complication has occurred. And sometimes they will, not treat it because they don't want to, think that the complications are occurred. But don't do that. That is where you will get into a soup. The fact that the complication occurred is not a problem. There are certain complications which are inevitable sometimes. If you're doing 100 cases, inevitably 1 or 2 cases may get complicated. So complication occurring is not what you should be worried about, but don't try and hide it. Don't try and not document complications or try and treat the complication. Okay, that is where you will get into more trouble than actually if the complication occurred. So the last case scenario for today is, so a 23-year-old lady, a pregnant lady, comes to you with a complaint of amenorrhea. So the urine test is positive. So the ultrasound shows the patient is 8 weeks pregnant. Okay, so she is basically requesting you to terminate the pregnancy. Now, her husband is not present with her. You feel, okay, it's a big decision that she's taking. You ask her to get her husband or maybe some attenders, and she says no, she does not want to inform her husband. Whatever the reasons, her personal reasons may be. So now what should you do? Should you go ahead with the MTP? This is a patient coming in with, yes, so, can the husband later come and create a problem? Can the family later come and create a problem that, this is our child? Why did you listen to the wife? The husband has a say on what happens to the child. So should you go ahead with the MTP or not? This is not a question of 20-30 weeks pregnant, when should you do MTP, not do MTP. That's a topic separately. I'm talking about come well within the time to do an MTP. You can do the safe MTP. The problem here is the patient is saying she wants it, but there's no husband. Maybe the husband is there and saying no. Maybe the husband is there but saying no, don't do the so what do you do in such situations is the question. So coming to the topic of informed consent, it's a very vast topic that will take an hour to discuss entirely by itself, but I just give about simple pointers here. Who is required to do it? It's the you need the consent of is the patient. You do not need the consent of the husband. Not if it's an adult, you don't even need the consent of an attender. Okay, as long as the patient is to give that consent, that is, they are not drowsy, unconscious, they're not undergoing. So say they're psychologically not in a situation to give that consent. As long as that is not there, they're completely conscious, they're completely able to understand what you're saying to them, they can give that consent. So in that same situation, who is required to give that consent? It's only the lady. To undergo MTP, only she needs to give a consent. You don't require the consent of the husband. Don't even require the consent of any other family member. Maybe all the family members are against it, but as long as you have her consent, you can go ahead with the procedure. So when do you need surrogate consent? So like I said, if the patient is unconscious, if the patient is in a drowsy state, not able to give consent, if it's a minor. So in all of these situations is where you need surrogate consent. You need someone else's consent as well. But in other situations, all you need is the patient consent. So when is it required? For what all procedures do you require consent? Obviously, any surgical procedure patient is undergoing definitely would advise consent, whether it's a small surgery, big surgery, anything. Now there's other questions of, there may be other medical procedures that are to be done. Show how procedures require consent. There's no law like that which says, okay, these procedures exactly require consent. What my recommendation would be is, if you feel there is any procedure which has a significant amount of risk of a complication occurring, then it's better to get the consent. Now, there may be, now people may say that, yes, when I give an IM injection also, the risk of, maybe patient has anaphylaxis, maybe patient has some other complication, even due to an IM injection. So, you can't sit and take consent for every IM injection also. So I understand that point. It's like I said, it's not about rare complication occurring. Yes, even with an IM injection, rarely something can happen. It's not about that rarest situation. We are talking about you feel commonly there is a significant amount of risk involved. So that's basically what I would say. If you feel there is a significant risk involved of a complication occurring, then yes, go ahead and take consent. My last point here, last tip to end would be definitely have professional indemnity insurance. Doesn't mean that just because they're in the rural setup, they are not going to take the legal route, that they cannot sue you. They definitely can. And they definitely have professional indemnity insurance. I'm not going to get into the nitty-gritties of which insurance, how much should it be, what are the factors. That's all, very detailed, very varied. A lot of factors play a factor in that. So I'm not going to go into that, but have professional indemnity insurance. Common question to me by junior doctors is, I'm just a registrar or basically just a duty doctor there. Do I need to have indemnity insurance as well? For them, I would just give this example that, say you're going deep sea diving, and in this picture, so you have an expert here and you have a novice here who's treating. Who do you think requires this oxygen cylinder more? Is it the novice or is it the expert? So it's obviously the novice who requires it more. So again, when it comes to insurance, actually, the junior doctors who need to have it than the seniors. The have either just experience of dealing with it, years of medical experience of treating different conditions, and maybe just the finances to sustain a, let's say, junior doctor. How capable you are, have that experience, there's more a chance that a mistake happens. There's more a chance that you may not be able to sustain financially that come with it. So you definitely even more than senior doctors, I would say. My take-home message would be, again, as understood, I clearly like making certain correlation. So this is an ostrich or an emu. So basically, there's this common saying, or at least I used to hear it in my school days, was that when an ostrich faces danger, what they do is they dig their head in the sand, thinking that if you don't see the danger goes away. Okay, so this is, I don't know if others have heard it, but I heard it. So this was the thing, that ostriches dig their head in sand to get away from danger. Obviously, we know it won't work, but scientists have actually researched this and found that ostriches don't do this. When faced with danger, what they do is they run. Okay, they don't dig their heads in sand. They dig their heads in sand because they lay their eggs underneath. So they're basically seeing the eggs. Okay, so my point here is that if even ostriches are aware, they're just putting your head in sand, saying that, okay, legal problems are not a factor, we'll deal with it when it comes. Is that going to work? Absolutely not. Ignorance is not bliss, knowledge is power. Okay, so how you react in danger is basically to deal with it, not by digging your head inside. And the same thing comes with medical legal problems. We know that it's definitely a concern now, and it's only going to increase with time. So how you deal with it is being aware of these things and taking it head on, rather than saying that, I'm not going to think about it and deal with it only when the problem comes. So this is just the details of my firm. If anyone has any queries, email us. If you're faced with any situation, you can email us. Yeah, thank you, Alumni Association, for this opportunity.
Dr. Satvik,
Thank you,
I
Dr.
just okay.
You can post it, and then maybe or you can reach out to Satvik directly, and then he can answer the question.
Sure, yeah. Can't hear you.
Hello, can you hear me now?
Yeah, yes.
Yeah. Okay, so we'll move on to the
Dr. Anjali, we are not able to hear you.
sharing your screen, we'll share it for you. We'll share.
The video? Okay. Yeah, it's fine. Working? No, I'm not able to hear you. Yeah, this is working now. I can't hear you also. Is it? Okay, can you hear me? the video? Yeah. We can. Okay, fine. Good. All right. Thank you. Okay. So good evening, everyone. I'm Dr. Gifty. So I will be speaking about non-operating room anesthesia adapting for rural settings. So this topic will be covered under the following headings, that is definition of NORA, then the various techniques of anesthesia that can be provided, and common procedures requiring NORA, and procedural sedation, local anesthesia, and regional anesthesia, a little bit in detail. So what is NORA? NORA involves providing sedation or anesthesia outside a traditional operating room setting. NORA is a growing field in healthcare, and unfamiliarity with the environment can be a challenge. It poses unique challenges in rural settings because of limited resources, potential for longer transport times, and specialized knowledge requirements. So NORA in rural settings, there is increased demand as more and more procedures are being done outside the operation theatre. And NORA can be provided in various settings, including radiology, interventional cardiology, and endoscopy units. So what are the different techniques that can be used to provide NORA? One is procedural sedation, next is local anesthesia, and the last is regional anesthesia. Out of these, the last two are more preferred in a rural setting. So the common procedures requiring NORA in a rural setup may include imaging procedures like X-rays and CT scans, endoscopy, postpartum tubectomy, from here, suture, reduction of fractures, foot, toe, finger amputation, debridement and tendon repair, upper limb and lower limb. Most of these procedures require procedural sedation along with local or regional anesthesia. So what is procedural sedation? It is the administration of a sedative or dissociative drug to relieve anxiety, discomfort, and pain during diagnostic or minor surgical procedures without loss of protective reflexes, mainly the airway reflexes. So goals include to provide analgesia and anxiolysis, maintain airway reflexes and spontaneous ventilation, ensure patient cooperation and comfort to facilitate a successful procedure. So what are the basic equipment that we need? So you need a patent IV access, oxygen source and administration equipment, that is a face mask or a nasal cannula, suction device, a good working suction, airway equipment, at least a bag mask device, and then again, based on your resource, availability, maybe a nasopharyngeal airway, a oropharyngeal airway, or a laryngeal mask airway would be great. Then medications and equipment for cardiac resuscitation include a defibrillator, reversal agents like naloxone and flumazenil if they're available, and monitoring equipment, at least ECG, blood pressure monitor, pulse oximeter, and if you have it in your resource, then an end-tidal CO2. So personnel involved in NORA, the healthcare provider administering procedural sedation and analgesia must be able to screen your patients and weigh the risk versus benefit. They should be aware of basic airway management skills like head tilt, chin lift, jaw thrust to maintain a patent airway, and bag mask ventilation. They should be able to administer safe dose of sedation and analgesic medications, including reversal agents, monitor airway patency and recognize signs of airway obstruction, assess adequacy of ventilation by checking the pulse oximeter and chest rise while providing sedation to the patient. They should be able to evaluate cardiovascular stability by monitoring ECG and blood pressure, and manage all potential complications. So the preparation includes taking a well-informed consent from the patient and the attenders, a comprehensive health evaluation, that is, you need to ask the patient the age, height, weight, ask for any allergies, comorbidities, medical history, and family history. Verification of the patient's identity and the procedure to be performed. Fasting status, that is NPO for at least 6 hours to solids and 2 hours for clear liquids. Assessment of airway difficulties or anomalies like a large face, large tongue, difficulty in extending the cervical spine. All these, are difficult airways. Then availability of required medications, including reversal drugs, and functionality of the monitoring devices. So the core sedative and analgesic agents are the following. The first one is midazolam, which is commonly available. It's a benzodiazepine, and the dose is 0.02 to 0.05 mg per kg. So typically for an adult, 1 to 2 mg is given IV. The duration is 30 to 60 minutes, and sedation with midazolam can be reversed with flumazenil 0.2 mg IV per minute, maximum of 3 mg per hour. So 0.2 mg IV can be repeated every 5 minutes. Fentanyl is an opioid. The dose is 0.5 to 1 micrograms per kg. The duration is for 30 to 60 minutes. It's a potent analgesic and provides mild sedation. Respiratory depression is very common with higher doses, which can be reversed with naloxone, 0.04 mg per minute, maximum of 2 mg every 4 minutes. Propofol is a sedative hypnotic. It's an anesthetic agent. 0.5 to 1 mg per kg IV is the bolus dose, and you have to titrate the dose as required. So the duration is 5 to 10 minutes. It does not provide analgesia, and it may cause hypotension and apnea. So you need to be very careful while administering propofol. Ketamine is a dissociative agent. The dose is 0.5 to 1 mg per kg IV. Duration, it lasts for 10 to 20 minutes, provides good analgesia, amnesia, and dissociation, preserves the airway reflexes, but emergence reactions are quite common with ketamine. So it has to be pre-medicated with midazolam. Dexmedetomidine is a newer sedative. It's an alpha-2 agonist. The loading dose is 1 micrograms per kg over 10 minutes, and maintenance is 0.2 to 0.7 micrograms per kg per hour. So it lasts for around 60 to 120 minutes. It may cause bradycardia and hypotension, but patients remain arousable and there's very minimal respiratory depression. So it's a relatively safe drug. Ketofol is a combination of ketamine and propofol in a 1:1 ratio. The dose is 0.5 mg per kg of each drug, IV bolus, lasts for 10 to 20 minutes. Deep sedation is observed with preserved airway. So there's analgesia with ketamine, sedation with propofol, and ketamine will reduce the respiratory depression caused by propofol. So it basically counteracts the negative effects. Next, coming to pethidine, it's an opioid. The dose is 0.5 to 1 mg per kg. Typically 25 to 50 mg can be given. And risk of seizures is there, and you need to avoid it in renal failure. Pentazocin or Fortrin is an opioid agonist antagonist. The dose is 0.3 to 0.5 mg per kg IV/IM, typically 30 to 60 mg. The duration is around 3 to 4 hours and may cause dysphoria. Promethazine, Phenargin, is an antihistamine antiemetic. The dose is 12.5 to 25 mg, and it enhances the sedative effect, and slow IV should be given. So what are the complications with procedural sedation and how to manage them? Respiratory complications include airway obstruction, so wherein the chin lift, jaw thrust maneuver can be used, and you can insert an oral airway or a nasopharyngeal airway if your clinical setting has it, and suction the oral cavity if needed. Hypoventilation, you can verbally stimulate the patient, or tactile stimulation can be used, reduce or stop the sedative, and provide supplemental oxygen. The patient may become apneic, during which you need to start bag mask ventilation and prepare for an advanced airway. Hypoxia can be present, and you need to provide high flow oxygen and address the cause of hypoxia. If it's obstruction, you need to maintain a patent airway and ventilate accordingly. The patient may even aspirate. So in that scenario, you need to turn the patient to the side, suction the airway, intubate if severe, and initiative supportive care, and consider antibiotics. The cardiovascular complications include hypotension. So you need to adequately hydrate your patient. Again, stop the sedative. Vasopressors may be needed. Patient may develop bradycardia, in which if symptomatic, you can give injection atropine, 0.6 mg IV, and stop the sedative. Hypertension may be seen commonly with ketamine. So just provide supportive care. And patient may also develop tachycardia, again, in response to pain or hypoxia and ketamine. So treat the underlying cause. Cardiac arrest is also quite common, in which scenario you're supposed to start immediate CPR and advanced cardiac life support based on the resources available in your clinical setting. Other complications include allergy, which has to be treated with corticosteroids and antihistamines. Pain at the site of injection is commonly seen with propofol. You can pre-inject lignocaine injection. Loxicard IV can be given prior to injecting propofol. The patient may also develop nausea and vomiting after using all these sedatives. So this can be tackled with providing an antiemetic to the patient. Neurological complications include prolonged sedation, which can be reversed with the reversal agents that I mentioned earlier, and emergence delirium commonly seen with ketamine. Midazolam 1 mg can be given prior to administering ketamine. The key risk factors for complications include age extremes, such as infants and elderly coming to your center, obesity, or patients with obstructive sleep apnea. So you can ask for history of snoring and take necessary precautions. Underlying cardiopulmonary diseases is a risk factor, inadequate monitoring or staff training, and polypharmacy, because all these sedatives have synergistic effect. So you need to choose your sedatives in a wise manner and use it carefully. Next, coming to local anesthetics, the commonly used ones are lignocaine and bupivacaine. Lignocaine has a faster onset. Bupivacaine takes 10 to 20 minutes to act. The duration is longer with bupivacaine. The dose without epinephrine, lignocaine without epinephrine is 5 mg per kg, and with epinephrine is 7 mg per kg. Bupivacaine without epinephrine is 2 mg per kg. Lignocaine can be used for infiltration and nerve blocks. Bupivacaine can be used for nerve blocks and spinal and epidural anesthesia. Lignocaine causes more of CNS toxicity in larger doses, and bupivacaine causes cardiotoxicity. So local anesthetic systemic toxicity is due to large doses of these drugs. So always know the maximum dose that you can use and accordingly administer to your patients. So CNS toxicity symptoms include tinnitus, metallic taste, agitation, and seizures. Cardiotoxicity with bupivacaine can present as arrhythmias and cardiac arrest. And treatment of the toxicity includes airway support, benzodiazepines for seizures, and IV lipid emulsion if it is available in your center. Also to note, avoid epinephrine in digital or penile blocks, skin flaps with marginal viability. So lastly, regional anesthesia. So the various blocks that can be used for upper limbs include axillary block, wrist block, and ring block. The relatively simple blocks to perform without an ultrasound guidance. The lower limb blocks include femoral nerve block and ankle block. So coming to axillary block, for surgeries involving the forearm, wrist, and hand, you can use an axillary block. The arm is positioned, the arm is abducted to 90 degree and elbows flexed to 90 degree. The trans-arterial approach can be used. So go high up in the axilla as possible, and the needle should traverse the artery at an oblique angle. Okay, so you go in with a 22 gauge, 1.5 inch needle, and you pierce the artery, go to the posterior. Once you exit the posterior wall of the artery, inject around 15 ml of local anesthetic there, which will block the radial nerve. And then you have to slowly withdraw the needle. And once you cross the anterior wall of the artery and there's no more blood spurting, you can inject the remaining 15 ml at that point, which will block the median and ulnar nerves. So a total of 30 ml is used for this procedure. So this is the anatomy. You can all go through the videos of all these blocks in nisora.com. It's very well, it's shown very well, and all of you will get a better picture of it. So this is the picture. This is how the hand is positioned, and the needle is inserted as high up in the axilla. So intercostobrachial nerve for upper arm tourniquet pain. That is, if a tourniquet is being used in the upper arm, then this block has to be given. It's a superficial block. Just infiltrate local anesthesia in an arc across the floor of the axilla from superior margin of the biceps at the anterior axillary line to the border of triceps. A total of 5 to 8 ml would suffice. Next is wrist block, wherein radial nerve, median, and ulnar nerve has to be blocked. So the first one is radial nerve. It's a field block, requires extensive infiltration due to the cutaneous branches. Slight dorsiflexion of the hand is the position, and local anesthesia is infiltrated in a subcutaneous plane 3 centimeters above the radial styloid, aiming medially towards the radial artery and laterally around 10 ml in total. Next is the median nerve, which has to be blocked. The forearm is supinated for this block. 2.5 centimeter proximal to the wrist crease between the tendon of palmaris longus and flexor carpi radialis. The needle is inserted until it pierces the deep fascia, and 3 to 5 ml of local anesthetic is injected here. Next, the ulnar. Under the tendon of the flexor carpi ulnaris muscle, just above the styloid process of the ulnar, around 3 to 5 ml of local anesthetic is injected. Also, you have to pronate the forearm, and a subcutaneous injection of 2 to 3 ml of local anesthesia blocks the cutaneous branches of the ulnar nerve. Next is the ring block. Injecting local anesthesia around the digit creates a ring of anesthesia, the web space block, and the modified transthecal block. So dorsal digital nerve and the palmar digital nerves are what has to be blocked. Next is the femoral nerve block. This can be used especially to position your patients coming with fracture femur for X-rays and other imaging that you transport the patient to. So the leg is supine and externally rotated. Needle insertion point is midpoint of the inguinal ligament below the inguinal crease, 1 to 2 centimeters lateral to the pulse of the femoral artery. 15 to 20 ml of local anesthetic is injected after you get 2 pops, that is the fascia lata and fascia iliaca. Next is the ankle block. This is again relatively easy. So the saphenous nerve, the sural nerve, and the superficial peroneal nerve are all superficial nerves, and this can be blocked with a subcutaneous ring of 10 to 15 ml of local anesthetic proximal to the malleoli. It's just a ring of subcutaneous infiltration. Next is the deep peroneal nerve. 5 ml of LA is just infiltrated lateral to the external hallucis longus tendon and the dorsalis pedis artery deep to the retinaculum. Posterior tibial nerve is you have to inject 5 ml of local anesthetic posterior to the posterior tibial artery midway between the Achilles tendon and the medial malleolus. Again, deep to the retinaculum. So to conclude, by addressing the challenges and implementing strategies for improvement, NORA can be delivered safely and effectively in your rural setting, ensuring that patients receive high quality care. Thank you.
Okay, so thank you, Dr. I understand that it's difficult for you to figure out how to do the blocks or anything, but like she said, you can access them all on nicora.com and you can see the video. It will tell you how to do it. It's just a question of what you need to keep prepared before that and what the dosages of the drug. So the slides will be shared to you and you can use this later. Okay, if you have any questions, you can post it on the chat group and she can answer it for you there. But we'll move on to the next one. So now we have Dr. Belinda, who's a professor and head of endocrinology and a UG/PG Journal, who will talk to you about the newer guidelines in hypertension and diabetes management.
Thank you, Anjali. Shall I try sharing my screen? Oh, you're already sharing it from there. Okay.
I will give you access. Just one moment.
Sure. Give me access. That's fine. So very good evening to all of you, and thank you, Alumni Association, for this opportunity. I have about 20 minutes, and I'll try my best to cover this vast topic in the next 20 minutes. I'll be as comprehensive and concise as I can. And we'll go through the slides quickly, and then if there are any questions in the end, if we have some time for discussion, we can.
Sorry, I'm not able to give the access. Would
You
you like to
move
share it?
You can move it for me, no worries.
Sure,
Is that?
done.
Should I try to share it once? Do we have time to attempt?
Yeah. You can try once.
Yeah. Is it visible?
Yes.
Okay, great. Then I'll use this. So today we look at the newer guidelines in diabetes and hypertension management. This is the overview. We will just look at the current guidelines, a broad overview, and then I'll spend a little time showing you the practical aspects of initiating and maintaining medications, both for diabetes and hypertension. I'll cover very, very briefly on insulin because it is too difficult to cover the entire thing. So largely for the diabetes, I've taken the ADA 2025 guidelines. So we'll start off with diagnosis. So if you want to remember 3 values for diagnosis of diabetes, these are the 3 values. Any A1C above 6.5, a fasting plasma glucose above 126 milligram per dl, and a 2-hour post 75 grams of glucose. If it is above 200, these values are diagnostic of diabetes. If the patient has very classic symptoms of diabetes, even a random plasma glucose value above 200 can be taken as conclusive evidence of diabetes. Now, once you have diagnose somebody with diabetes, and every time the patient comes to see you, there are certain essential things that we should not miss. So what are those things? Like we remember the triopathy, that is neuropathy, retinopathy, nephropathy from our undergraduate days, but it's slightly expanded today. So you have to look at any cardiac involvement or cardiovascular risk factors by assessing. There are many risk scores. You can use any of them to assess. You should look at involvement of kidney. This is the nephropathy that all of us are used to, the retinopathy, the neuropathy. You should also assess if the liver is involved, because currently MASLD, which is a new terminology for involvement of liver in relation to metabolic associated diseases, is an emerging concept and a very important risk factor for developing cirrhosis. So this is something that we should screen all our diabetes patients for. So once you have assessed their either in the baseline or in your follow-up annually, it is important for us to assess involvement of these organs as well. So once we have done that, the next step is to set a goal. So every patient should have an individualized goal, whether it is for blood glucose control, the HbA1c level, the lipid goal, or the hypertension. For all of them, there will be a specific goal which is individualized based on the patient's risk factors, age, comorbidities, etc. And then we can decide how to initiate pharmacotherapy and how to titrate pharmacotherapy. But irrespective of our pharmacotherapy, every patient should receive lifestyle changes and advice related to lifestyle changes for all of these, for glycemia, for blood pressure lowering, for dyslipidemia, and for obesity. So all these 4 aspects, and just not glucose, should be the focus of our therapy when we are managing a patient with diabetes. So this slide shows you how to individualize therapy, and though this slide pertains only to diabetes risk goal calculation, you can actually use it for approximately for everything. Your goal setting can roughly follow the same guidelines. So if you have a younger patient without any other comorbidities who is highly motivated, then your target should be as close to normal as possible. So if you're talking about glycemic goals, you can set an HbA1c of 6 or maybe even slightly less for this patient who's young, just recently diagnosed with diabetes, do not have any major comorbidities, and is quite fit and well, and can do a lot of the lifestyle changes that we have advised and will stick to therapy. So apart from being young and not having comorbidities, one of the biggest challenges is their lack of motivation. So a motivated patient, definitely you can target a great HbA1c, but in the same scenario, if the patient has zero motivation, then every time we hike up the dose, there will be a risk for hyperglycemia. So in them, maybe we can relax the A1c to maybe around 7, or in some cases 7.5. But as your comorbidities increase, as the age increases, as complications of diabetes sets in, you do not want to keep the same A1c goal, because the lower the A1c goal, the higher the risk for hyperglycemia. And hyperglycemia, as we know, can only cause harm to the patient, and that to immediate harm, not just because of the acute hyperglycemias, but also because chronic hyperglycemia, first of all, will lead to unawareness and then can predispose to arrhythmias and cause death. So mortality is definitely increased if there is higher risk of hyperglycemia, which is the reason why we relax our control when we are unable to achieve good control. So the crux is, if you can achieve a low A1c without hyperglycemia, then go for it. If not, do not subject the patient to intensive therapy. So what are the, we already know that we have to individualize the A1c, but how do we achieve an A1c less than 7? So like I showed you a couple of numbers before, if you want to remember 3 numbers when you're following up your patients with diabetes, any pre-meal value, whether it's fasting, pre-lunch or pre-dinner, between 80 to 130 is a decent goal. Less than 80, again, risk of hypoglycemia is less, so you might want to reduce your dose. And a post-meal target of less than 180 usually is that's what corresponds to an A1c on an average to 7. So if your target was 6 for that patient, then your 2-hour post-meal can actually be maybe 140 or less. So you can individualize this as well. But for an average healthy adult, these numbers are good to remember: 80 to 130 for pre-meal values and less than 180 for post-meal values. And if you're able to achieve that most of the time, your A1c is likely to be closer to 7 or less. And we have to do all of this while preventing hypoglycemia. So any glucose level seen at any time of the day less than 70 can be taken as hypoglycemia, even though a patient is not symptomatic, because once you have a glucose less than 70, another glucose value which is lesser than maybe 54 is highly likely, which is why at 70 itself we intervene and start de-intensifying our therapy, because we don't want a patient to go for repeated hypoglycemias. So I'm gonna, in the interest of time, I'm gonna skip these two slides, but I'll tell you what the gist is. Basically, ADA recommends that when you start the patient on therapy for hyperglycemia, the most important risk factor to look at is what is the patient's cardiovascular risk factor. Does the patient already have an established cardiac disease? Does the patient have heart failure or atherosclerotic coronary artery disease? Does the patient have CKD? If any of these diseases are present, then there's a compelling indication to use two particular agents, which is GLP-1 receptor agonist or SGLT2 inhibitors. But in our country, currently GLP-1 receptor agonists are extremely expensive, so it may not be feasible for all of us to use it. So I'm not going to discuss GLP-1 today, but we will look at SGLT2 inhibitors and a host of other anti-diabetic agents that we have. So if the patient doesn't have any compelling indication in the form of what I just mentioned, then you can use any drug. Only you have to be cognizant of the fact that obesity and weight are so closely associated with diabetes and its complications that whenever you're writing a drug for glycemia, think about its impact on weight and try and use weight-friendly medications. So we will just broadly look at the OADs that we have. Till a couple of years ago, maybe last 2 years, the recommendation has changed, but till such time, metformin was always advised as the first drug to initiate the patient on. And the only exception is when there's intolerance or any end organ damage where you cannot use metformin. However, today, metformin is no longer considered to be used only as a first line drug. Depending on patients' comorbidities, you can try other medications as well. But metformin is a drug in our kitty that has stood the test of time. We have used metformin for more than 50 years. So we know that it's a safe drug. It's very, very well tolerated. The maximum dose is up to 1 gram twice a day. The commonest side effect you will have is GI intolerance. So whenever you start medication, don't start 1 gram twice daily. Start with 500 mg once or twice a day, and then up titrate it to 2 grams per day, which is a full proper dose of metformin. Only if the patient develops renal dysfunction, we'll have to down titrate the dose appropriately. Other medications that we have apart from metformin, I will look at these very briefly. We have DPP-4 inhibitors, we have SGLT2 inhibitors, we have thiazolidinediones, and we have sulfonylureas. And lastly, we have insulin. When every other drug fails, we have to turn to insulin because that is the only option we have. So earlier, maybe about 10 or 15 years ago, we did not have access to DPP-4 inhibitors because it was not so affordable. But currently, all DPP-4 inhibitors except linagliptin has lost its patency, and so they are available for relatively at a cost-effective rate, I would say. The two common drugs which we use in clinical practice are sitagliptin and vildagliptin. In between, we use teneligliptin a lot, but nowadays, because these two are available at affordable prices, we have stopped using teneli because we do not have much data with teneli. So sitagliptin is given as 100 mg once daily. It's generally a very well tolerated drug. Vilda, on the other hand, is ideal dose will be 50 twice daily. You also have an OD preparation, but the 50 BD works a lot better. The only thing that in Vilda that you have to be careful is occasionally it can cause some AST/ALT elevation, which actually reverts normal on stopping. So this is a good practice to check it when the patient is on vildagliptin. Apart from that, if you look at DPP-4 inhibitors, generally they are one of the safest drugs today that we have. So even in elderly and people with other comorbidities, generally it is a drug that we can use quite easily without too much of concern. Even in renal failure, Sita and Vilda can be used, but with dose modification. And linagliptin is the drug that can be used without any dose modification in renal failure. So when patients develop CKD, you you probably will see that a lot of patients are being switched on to linagliptin. But if the patient is already on Sita or Vilda, it is really not necessary. You can just reduce the dose and you can continue that safely. The one thing that we have to remember is DPP-4 inhibitors have been associated with bullous pemphigoid. So if there is any skin lesion, please either examine yourself or take a dermatology opinion. And if there's a doubt if there is the patient may be having bullous pemphigoid, then these drugs are contraindicated in those patients. And someone with a diagnosis of bullous pemphigoid, generally we don't start. Another black box warning is arthralgia. So if your patient has significant arthralgias which is not explained by any other reason, you can give a trial of stopping your gliptin or DPP-4 inhibitor and see how the patient responds to it. But overall, this is one drug that we can use quite safely without having to worry about is a creat normal, is a AST/ALT okay, are other end organ damages okay. So if the patient is otherwise stable, even without screening them for all of that, we can write DPP-4 inhibitors. The next class of drugs is SGLT2 inhibitors, and I'm sure you all are familiar with these three names, DAPA, EMPA, and CANA, which is what currently we have in our country. So DAPA is the most commonly prescribed among three of them because that was the first one to become cost effective. It's given at a dose of either 5 or 10 milligrams per day. The good thing about SGLT2 inhibitors is that they have been proven to have cardiorenal protection, and it's most likely to be a class effect and not a drug effect. So irrespective of which drug you're using, you're likely to get the benefit. The flip side, of course, is genital mycotic infections and euglycemic decay. So every time you start the patient on an SGLT2 inhibitor, it is important to tell them that there is a possibility. It may be a small percentage, maybe about 5 to 6% chance of genital mycotic infection based on Western data, and even less in the Indian subpopulation that have been studied. So, but you should always make them aware. Otherwise, sometimes patient will not realize the drug is causing it and continue to suffer without reason. If the patient develops a genital mycotic infection, you can treat it with fluconazole and reintroduce the drug again to see, because majority of the time these infections are secondary to hyperglycemia and not just the drug alone. But there are a few patients who get recurrent mycotic infections with SGLT2 inhibitors, and in them it's best avoided. Another complication that we should be aware of something called euglycemic decay, which if you do not recognize, the patient may unfortunately continue to suffer. So this usually happens in elderly, in patients who are fasting, who are going for surgery. So these are and acutely ill patients otherwise. So whenever patient is admitted with an acute illness, intercurrent illness, or if the patient is going for surgery, or if the patient is NPO, the recommendation is that SGLT2 inhibitor should be withheld for a period of 2 to 3 days. EMPA, again, very similar to DAPA, description-wise, and the dose is slightly higher, 10 or 25 milligram per day. CANA has not lost its patency yet, so it's a little difficult. It's expensive even now. It's also having some problems with distribution, so CANA is actually difficult to obtain these days, but otherwise it works equally well. So currently, SGLT2 inhibitors are extremely popular in the among the anti-diabetic agents, and one of the most important reasons is that it does induce weight loss. The weight loss quantum may be less; it may be just 2 to 3 kgs or maximum 5 kgs, but still, when you look at all other medications, this is a huge advantage for SGLT2 inhibitors. The only thing is that it might cause genital mycotic infection in a small subset of patients, but otherwise it's becoming extremely popular because of its cardiorenal benefits as well. So coming to TCDs, this is drastically come down, particularly because rosiglitazone was involved in a controversy, and so that's no longer available, it's no longer used. Whereas pioglitazone is still available, and one of the main side effects is that it causes fluid retention, so it causes edema, weight gain. It cannot be used in patients with CCF for the same reason. It will worsen cardiac failure. In CKD, again, already fluid overload states might worsen it, but otherwise it doesn't cause any damage to the kidney. It is good for the liver. Pioglitazone is actually beneficial for NAFLD and MASLD, and it is also good for stroke and atherosclerosis. So, but because of too many other side effects, generally pioglitazone is less used compared to other drugs, but otherwise it's a potent drug, and particularly in post-menopausal women, it's best avoided because there's risk of osteoporosis and fractures. So in young men or young aged individuals and in men across all ages, it's an excellent drug, particularly at small doses, because the effectiveness is good. And if you do not have too many choices, then TCD is a great choice. Sulfonylureas is at once, maybe about 20 years ago, was a ruler, but now has really dropped. Its position has gone down heavily. So these are the common sulfonylureas that you're familiar with. Glibenclamide is extremely potent, so risk of hypoglycemia is very high. So I think if somebody is on glibenclamide, maybe you can continue it, but do not start anybody on it because the risk of hypoglycemia is too high. Glyphosate can be used in CKD as 5 and 10 mg, not as potent as the others, but has its benefits. Glycoside, on the other hand, is another potent SU, which has shown some beneficial effects on the heart. So generally, if you have to use an SU, you probably should use glycoside or glimepiride. Both of them have some beneficial effect on the heart. So if you have to use a sulfonylurea, I would choose glycoside or glimepiride. And I would definitely avoid glibenclamide, except in cases when someone's already on it for many, many years and is doing quite well. So now, just to break the monotony, I have just introduced the case. I'm sure we are not able to talk and you probably won't be able to answer. But here is a patient, a young patient who's come with new onset diabetes and has all symptoms of hyperglycemia, polyuria, polydipsia, weight loss, and severe fatigue. And you can see that the HbA1c is very high, and both fasting and postprandial glucose is also very high, 300 and 400. So among all the medications I mentioned, I hope you're thinking what is the best choice. And I hope some of you also thought about insulin, because anytime the patient is having severe catabolic features, insulin is the best option, because your medications are not going to work so well when the patient is having such severe hyperglycemia. SGLT2 inhibitors is a medication that we will definitely avoid, because this hyperglycemia patient is already predisposed to genital mycotic infection. And SGLT2 again causes further weight loss. So in patients with severe hyperglycemia, we definitely do not recommend SGLT2 inhibitors. DPP4 inhibitors you can, but remember they are not very potent. So the A1C reduction is maybe about 0.5 to 0.6. So you're not going to get excellent A1C reduction or the target that you need, you're not going to achieve with that. Sulfonylurea is a potent drug, definitely has a role here, but there is a phenomenon called glucotoxicity. So when glycemia is very high, the impact of these agents in the pancreatic beta cells will be sort of hindered to some extent, so they may not work very well. So for all these reasons, ideal agent would be insulin to bring down the glycemia very quickly. And once you control it, then you can reintroduce your OHAs and they're going to work much better, and their durability is also going to be better. So I'll just introduce the different types of insulin. I'm not going to spend too much time on various regimens, but you would have seen this is the regular insulin. This is Actrapid, Huminsulin R, Insugen R. They are all regular insulin. They are the short-acting insulin, which should be given along with food because they will cover the post-meal excursion. Then you have NPH insulin, which is basically your intermediate acting insulin. So it's either called Insulatard or Huminsulin N, Insugen M. And this is usually given to cover your basal requirements. So because it's intermediate acting, if you're using this, ideally you should give it twice. Then of course you have premixed insulin, where you have combined the R component and the N component in different combinations. You can get 30-70, 50-50. These two preparations are quite popular in our country. The 30-70 means you have 30% of regular insulin and 70% of NPH insulin. And 50-50 is half of both. Then you also call something called insulin analogs. Insulin analogs basically means, the insulin structure. If you see this blue picture where the insulin structure is seen, you can see that when we tweak the insulin structure here and there, add a couple of amino acids, we can change its mechanism of action to our advantage. We can either make it act longer or we can make it act shorter. So that's what insulin analogs are. Either they will act much faster, so your post-meal control is much, much better. So they're called rapid acting, or you will have very, very long acting, which sometimes we can take every 24 hours, but actually it acts longer than 24 hours, so it reaches a steady state. So this is essentially what insulin analogs are. And if you have any doubts on a specific insulin, you can always ask me. This is again showing you the graph. The blue graph is a very, very short acting, the quick acting insulin analog. The red graph is actually showing you how actrapid or insulin regular acts. The green line is showing you how insulatard or the NPH insulin acts. See that you can notice that it wanes off about 14 to 16 hours, so you cannot get away with once daily insulatard in a person who is completely insulin deficient. So you have these newer basal insulin analogs which acts for more than 24 hours. So then you will ensure that insulin coverage is there through 24 hours a day. So basal insulin, what does it do? It will control your fasting and pre-meal values and it'll act throughout the day. Prandial insulin is actually the mealtime insulin. So it'll act for maybe 4 to 6 hours and it has to be taken with every meal, ideally. So when you're using a premix, you can give it once morning and once night. And you will hope the intermediate acting will also have some impact on the post-lunch glycemic excursion. Now, there are multiple devices, but the two commonly used devices in clinical practices, one is the vial. So you need a syringe to withdraw the insulin from the vial. The only thing to remember is that unfortunately in India, there are two concentrations of insulin. There is a 40 IU insulin and there's a 100 IU insulin. So you should ensure that every time you're using an insulin vial, make sure that the syringe matches the concentration. So if you're using a 40 IU vial, ensure you use a 40 IU syringe. If you're using a 100 IU vial, ensure you're using a 100 IU syringe. So for the pen, that does not matter because it's a much easier to use device. And insulin pens also becoming quite popular these days. So when we start insulin, we can always give in a patient with type 2 diabetes, we can always try only basal because you're hoping that the oral anti-diabetic agents will take care of the post-meal excursions. So that is one very popular regimen, particularly when you're initiating insulin for the first time. Ideally, the perfect regimen should be when you're giving one basal insulin and prandial insulin with every meal. So 3 prandial doses and 1 basal insulin if you give, that is what is called the basal bolus regimen. And of course, the most popular one is premixed insulin, where we can give the mixed one 30/70 twice daily. So earlier we saw a young guy who had come with very high glucose. Now here we have a patient who's already having diabetes for a long duration of time, is currently on metformin and glycoside, and also taking insulin, fairly stiff dose, 25 units morning, 25 units at night, and still your HbA1c is sky high with uncontrolled hyperglycemia. So what are the things that you should do? Should we be changing the dose insulin? Should we increase the dose of insulin? Or should we just continue the same? So I'm just going to answer the questions here. Every time you have uncontrolled diabetes, please go back and check the compliance with medications, diet, and physical activity. Also see if the medications are bought from appropriate places. Is the insulin bought from a good medical facility where it is stored appropriately? Because if you do not store insulin properly, it loses potency in no time. It's very temperature sensitive drug. And where is the patient himself or herself storing the insulin? Then how they're injecting the insulin, what is the technique? Also, always examine the site for lipodystrophy, because that is the most common reason for having uncontrolled hyperglycemia in patients who are on insulin. Finally, of course, you can up-titrate or intensivize the regimen. So very briefly on hypertension, this is the ADA recommendation. If somebody with diabetes has higher BP readings, anybody with 150/90, you can initiate on 2 agents, and anybody who's 130/80 and above, you can initiate on 1 agent. This is the current ADA recommendation, and your target is always 130/80. What are the drugs used? ACE inhibitor, ARB, CCB, diuretic in any order. The only time when you have to preferentially use ACE inhibitor ARB if there is any kidney or heart involvement. This is in a non-diabetic patient, the current guidelines, but it mirrors it so much so that I think we don't have to break ahead teasing out 120/70, 130/80. I think you can remember that anybody with 130/80, it's a good practice to initiate medication, and the target will also be always less than 130/80. The same drugs are recommended here also, ACE inhibitor ARB or CCBs and diuretics. So the strategies, if you have to look at antihypertensive agents, most of the time you can start with either ACE inhibitor or ARB. Remember, ACE inhibitors and ARBs are not very potent drugs. So if your BP is quite on the higher side, then I would rather use a CCB or a diuretic, or you can use a combination of ACE inhibitor or ARB with a diuretic. The next drug, if you're not able to achieve good control with these three agents, then you can consider beta blockers, particularly if there's another compelling indication like a cardiac involvement. If nothing else is there, then MR receptor antagonist is a very good choice, like spironolactone. And now you have newer agents also which are coming in, which are which have very beneficial effects on the kidney. So when do we start BP medication? I think everybody who has persistently high BP above 130/80, or if the readings are above 150/90, even once in patients with diabetes, you can start. In a non-diabetic patient, maybe above 180/110, you don't need to reconfirm it. You can consider it as hypertension and initiate the patient on medication. The strategy should be combining smaller doses of different molecules rather than taking one drug and trying to push it up to the full dose, where you might end up with side effects. So for example, if I want to control blood pressure very well in a patient, let's say patient's BP was 170/100, then I wouldn't really mind starting the patient in a young patient around 45/50. I wouldn't mind starting a triple combination and down titrating it. Or more often in clinical practice, I will start with dual agents and then up titrate if I have not achieved the target of 130/80 by the next visit. Of course, every patient should also receive lifestyle modification, whether it is for diabetes or hypertension. So when we talk about comprehensive management, it is not just glycemia, it is just not blood pressure alone. We have to address the patient as a whole. Lipid management is very important. Weight management is very important. And now we have agents which are beneficial for both heart and kidney, which is essentially a SGLT2 inhibitor, your GLP-1 receptor agonist, and your MRAs, non-steroidal MRAs. So these are the three agents your patient can afford, can consider adding these to your kitty as well. So that is my last slide. I think it's important not to forget comprehensive management beyond glucose and BP. Cost-effective regimens are key in resource-limited settings, and currently we have a lot of options to choose from. And education and reinforcements during all visits are absolutely necessary and mandatory, because when the patient is diagnosed with diabetes, they will be very, very closely adherent to both medication and lifestyle changes. And over a period of time, slowly that motivation is lost. So reinforcement and re-education at multiple visits are absolutely essential. And lastly, I'd like to conclude by saying whenever you see patients with excellent control of diabetes, you should always credit the patient so that they also feel good. And without the patient's effort, it's not that easy to get excellent control. Thank you. I hope I didn't overshoot my time.
No. Thank you so much, Belinda. That was excellent. And I know that you probably will be sharing the slides as well. But if you have any questions, we can't take them live now. But if you have any questions, you can put them in the chat, and then maybe Dr. Belinda can answer them in the chat thing, if that's okay. So
Sure. Thank you. Thank you.
Thank you so much. We'll move on to the next topic by Dr. Soumya Umesh, who's a professor in general medicine in St. John's. This is a very specific topic. It's about how to manage accelerated hypertension in an emergency setting. So it is also supposed to be interactive, but if it depends on how Dr. Soumya, what responses she gets. So we'll see how it goes.
Thanks, Anjali. I hope I'm audible. They
Yes,
told me
yes, you are.
They told me it is an interactive BP management for accelerated hypertension. So I made no slides. And the other thing is I'm happy to go after Belinda. She's already set the stage for the importance of BP and sugar control. So we all know in today's day and age, BP, sugar, and LDL have to reach their goals. Then only we are going to be able to reduce morbidity and mortality. Okay. Topic that has been assigned to me is accelerated hypertension. So in the next 15 minutes, I want you all to pay attention to me. I will give you only key messages that you need to take, right? Now, the terminology is continuously changing. There are words like severe hypertension, markedly elevated hypertension, asymptomatic severe hypertension, malignant hypertension, urgency, crisis. So many things are there, and the terminology is constantly changing. Don't get overwhelmed with these terminology. There are just few basic principles that if you follow, you will be a safe for your patient with a high BP. Everybody, as of now, the recommended target is 130/80. So with very good drug usage, and people are more aware, BP monitoring has become more continuous, more frequent. So the number of people coming to your OPD or emergency with a BP, very high BP like 181, for practical purposes, today's purposes, we'll consider the BP of 180, 120 as significant. Systolic 180 and diastolic around 110 to 120, severe hypertension, let's take. Now, the number of people coming to hospital with 180, 110 is slowly coming down because of rampant BP control. So overall, we are doing a good job. Patients are more aware. Still, they will come to you. And believe me, anybody who comes to the emergency department with a BP of 180, 120, emergency means hypertensive emergency, is likely to die either in hospital or will die in the coming coming 2 to 3 months. So the mortality is 50%. So what I want to tell you, this hypertensive emergency is a very big deal. Now I'll give you two situations for you to understand clearly what you're supposed to do and what you are not supposed to do. What you're supposed to do is one thing, what you're not supposed to do is another part. I'm going to discuss it so that you'll understand very clearly. Not supposed to do is almost as important as what you're supposed to do. Now, most of you have seen us in medicine OPD, we measure the BP. So the patient can come in two ways. One is medicine OPD and the other patient is coming to emergency. Medicine OPD patient has come, he or she has come with a BP of say 180, 110, 180, 120. You are examining the patient, you found that the BP is high and you ask or assess the patient for something called as target organ damage. For the purpose of this talk, I want you all to remember it as ATOD, means I am bothered whether the patient has acute target organ damage. Okay, target organ damage, all of us know. But for this talk, whether an elevated hypertension is significant or is urgent or not, I will know only if I figure out whether the BP is acutely elevated with an acute target organ damage. Fine. Before I go on to what we are going to do in OPD, what we are going to do in the emergency department, what are the target organs? We'll do it head to toe. Most important is brain. The autoregulation is very, very, very strict with the brain. So if we drop the BP, the brain will lose its blood supply and it can cause catastrophic problems. So patient came with you with one problem, you don't make it worse by giving him or her more problems. So this is the first thing that you have to remember as an acute target organ damage. So in the brain, what are the things that can happen? Subarachnoid hemorrhage, any infarction, intracranial bleed, or something called as hypertensive encephalopathy. These are the list or cerebral edema because of malignant hypertension, which will reflect in the eyes as papilledema. So this much I spoke to you about the brain. The next target is the eyes. We're going like this, okay, head to toe. It's easy for us to follow. The next one is the eyes. So retinal hemorrhages, acute retinal hemorrhages, and papilledema, these are the important things. And usually if it's a prolonged hypertension, long period of uncontrolled hypertension, you're likely to say all these, background changes, narrowing, hemorrhages, flame, all of those. But acute changes in the eye are what you need to be bothered about. Lower down, most important is heart and the biggest blood vessel in the body, which is the aorta. So there is a high BP and the heart is pumping against that. And if it's an acute target organ damage, the heart is likely to experience two problems. One is it's not able to manage the blood supply, so the patient can have angina or infarction. Second, the pumping is not effective and therefore the patient is likely to have pulmonary edema. So third, what did I tell you about the biggest blood vessel in the heart? That is the aorta. And the high BP starts dissecting the aorta, and that's called a dissection of aorta. So what have we done? We discussed that we are going to talk about an elevated BP with an ATOD. ATOD means acute target organ damage. And what did I tell you? BP of more than 180, 110, which has risen acutely. First one I told you was stroke, either an infarct or a hemorrhage or a subarachnoid hemorrhage or malignant hypertension where the brain becomes edematous. Second, eye. Third, what did I tell you? The BP is so high, the heart is pumping, it's unable to pump. Therefore, it results in pulmonary edema, or it becomes ischemic, and that results in angina. Third, what did I tell you? As the blood goes out, aortic dissection. So much so for the cardiac complications. Next set is renal. So, in the definition for hypertensive emergency, we are going to say that if the creatinine goes up rapidly from normal to this thing, and also if there is a what you call as microangiopathic hemolytic anemia because of the severe malignant hypertension, these are other complications, but the less common, the more things that you're likely to encounter is the brain, eye, and the heart. Okay. Now, when the patient comes to my OPD and I find that the BP is 180, 110, this is the background knowledge that I should have. I will seat the patient, make the place less noisy, reassure the patient, make sure that I follow the correct technique to check the BP, which would include seat the patient properly, give them a back rest, make sure that there's no pain, no noise, no recent intake of coffee, all of these things. Rest the hand on the table, don't leave it hanging or down like this. Make sure that there's no coat, sweater, that, this and the other things that will actually, make us overestimate the BP. It should be a bare hand, but it's not practical to make it a bare hand. So you make sure that over a single clothing layer, you check the BP properly. Make sure you do all of this. If the BP is more than 180, 110, and there are no symptoms. What are the symptoms I told you? Nothing suggestive of severe headache, nothing suggestive of a stroke, no seizures, no neurological deficits, no headache, none of these, then I'm little reassured. I'll ask for visual symptoms, loss of vision, any of these things. And I'll ask, do you have chest pain? Do you have breathlessness? Has your urine output dropped? Are you having any chest tightness or breathlessness? You ask these questions, and the answer to all of this is no. Then I'm going to label this patient as, let's remember it as ASH. ASH stands for asymptomatic severe hypertension. Let's say it again, ASH, meaning asymptomatic severe hypertension. It is a severe hypertension because the BP is more than 180, 110, but it is asymptomatic. And I don't need to act very urgently on this. This patient, I'll check BP on both the hands. Also make sure, it's very, very important. Often we forget to check BP on both hands. It's important because there are several patients who can have coarctation of aorta. Though rare, it's still possible. And other peripheral vascular diseases, sometimes the worst and most sinister diagnosis for difference in BP is dissection of aorta. You miss the dissection of aorta, you'll have a dead patient, something which has such a very, very high mortality. Okay, so we check BP on both hands. Make the patient lie down, check the BP, make the patient stand up, wait for 2 minutes, check the BP again to see if there is any orthostatic fall in BP. Orthostatic fall in BP is a pointer towards secondary hypertension. If the BP goes up, it's a pointer towards essential hypertension. I hope I'm clear about that. Okay. So in my OPD, I find this patient, see the patient, check the BP properly, and I find that there is no acute target organ damage. I will reassure the patient. In fact, half an hour, you make him sit down, make him or her sit up, check the BP again. Check the BP again. If it's coming down, then you reassure the patient. If you still find that the BP is high, what you have to do is to start the patient on a calcium channel block. I'll tell you why I prefer a calcium channel blocker like amlodipine or cilnidipine, all of these drugs, is because we don't know in the OPD whether it is still renal failure is there, whether it's a secondary hypertension, whether a beta blocker is contraindicated like in a pheochromocytoma, what is the potassium, can I give a diuretic, because I don't have a creatinine or my potassium in my hand. So what I will do, the safest is amlodipine, start a small dose like 5 milligrams. Don't be in a race or a hurry to see normal BP. It's not required to see the normal BP within 1 or 2 days even. Because what did I tell you? It is ASH. ASH means asymptomatic severe hypertension. Reassure the patient. Send all the tests that you want to send for your hypertension assessment. In a week, the BP will come down for sure. And in about the next OPD visit, you'll be wiser with respect to whether this patient has primary hypertension, secondary hypertension, renal failure is there, not there, potassium is there, diabetes is there, dyslipidemia is there, obesity, all of these, you'll be able to make a comprehensive assessment maybe in the next OPD visit. But make sure you get the ECG before you send the patient. Are you okay with this? Create potassium, ECG, all of these are important. Okay. So the key message I gave you, if the patient has come to OPD, Make sure your BP measurement is correct, and anything that is telling you, oh, this patient is sick, there's something not okay, check the pulse ox, check the ECG. If you are in doubt, admit the patient for further workup. Otherwise, the patient can be discharged, making sure that he or she comes back to you at the next visits, emphasizing that the BP should come down to less than 130 in the coming weeks. I'd just like a few upvotes at least to say whether I'm clear about the OPD patient, which is ASH, meaning asymptomatic severe hypertension. I'll still stick with amlodipine or cilnidipine just because I want to be safe with respect to creatinine and potassium. Hope I'm okay with this. Are you all okay with this? Okay. Done. Safest is amlodipine. Don't be in a rush to see a normal BP of 130, 80 or 120, 70 within hours or days. Done. Now, so the next part I'm telling y'all is something much more serious. So here there is a BP of 180, 110 or 180, 120, and the patient has something called ATOD, means ATOD is what I've coined, so that you all don't believe that a chronic target organ dysfunction will come under this. What will come under this will be only acute target organ damage. What I'm going to suggest to you all, I've already told you all the list of the acute target organ damages. Put the patient on the bed, because this hypertensive emergency, what we are talking about, is a hypertensive emergency. Treat it like an emergency. Keep your crash cart next to you. Activate your emergency people. You would have learned in emergency how you have to position yourself. Put the patient pulse oximeter, check the GRBS, assign a team leader, keep your crash cart close to you, connect all the monitors, which will include your ECG leads, connect to the monitor, put the BP, but don't believe the BP that's automatic. Always check manually. So if you have a BP of 180, 110, and the patient has either headache or a neurological deficit or a seizure or lost consciousness or severe headache or loss of vision or chest pain or this breathlessness, then you have to take it very, very seriously. This patient will need emergency referral. What I would suggest is prop up the patient at 30 degrees, attach all the monitors, check the GRBS, send a VBG if possible. I don't know whether in your setting you'll be able to get a VBG or not, because a VBG will urgently, and also ask for a urine monitoring. Don't be in a rush to put the Foley's catheter, but at least put a condom catheter to know whether urine is coming or not. This will tell me whether there is renal failure or not. Okay. You make sure that there's a team leader, have your crash cart, make sure that the monitors are going continuously, because this patient can slip and die any moment. So you have to be absolutely vigilant with this patient. Now, I will have to make a diagnosis whether this patient has a hypertensive emergency because of a CVA, because of ischemia, or hypertensive emergency CVA because of IC bleed, or whether it's a cardiac event. To make it simple, for hypertensive emergency, there are only 2 drugs that you need to remember. I want all of you all to pay attention to remember these 2 drugs. In our setting, we need only 2 drugs that you need to. That is, one is IV labetalol and the other one is NTG drip. There are several other drugs. I don't need you all to remember all of that. Only these 2 things are important: labetalol and NTG drip. Okay. Now, whenever there is, if I find, do you have a CT in your machine, CT machine in your this thing? Make sure somebody is taking the ECG. Quickly have a look at the ECG. If there's ST elevation, what does it tell you? That the patient has acute myocardial infarction with a high BP. That will go as ACS pathway. If the patient has a lot of ECG changes, ST depressions, breathless, JVP is raised, pulmonary, hypoxia is there, and on auscultation you have crackles, then what hypertensive emergency do you have? High BP with acute pulmonary edema. Okay. If the patient has, I told you, neurological deficits, unless you have a CT scan, you won't be able to make out whether it's an infarct or a hemorrhage. Why it is so important to make out whether it's an infarct or an hemorrhage? In infarct, you should not bring down the BP as far as possible, because if we bring down the BP urgently, the brain's autoregulation will fail and the patient will become much worse. So be very, very careful. If there is an infarction, I'm more concerned about getting the patient in time for a thrombolysis. Okay. So mustn't drop the BP too much. Bring down the BP only if it is more than 220 by 120 or 220 by 130. That too, how will I'll finish off the don'ts. The don'ts are very, very important. I'm telling all of y'all, please don't give IV Lasix 20, 40 just for the heck of it to bring down the BP. The problem is you're going to dehydrate the patient. The autoregulation will get messed up. We don't know what the state of the brain, the kidney and all is. And third is the BP will drop and you'll have absolutely no control over the degree of drop. Because for hypertensive urgency, the drops are very, very careful. So what did I tell you? Patient has come to emergency. What did I tell all of you all? Make sure that you have a crash cart, arrange yourselves properly, check the GRBs, send the VBG, put all the monitors, put a Foley's or a condom catheter, get the ECG first, then you'll go along this path. Correct? No? All of you are okay with me so far? Then I told you the don'ts. Don't give Lasix. What is the only condition where you'll have to give Lasix? I already described that to you. When there is pulmonary edema, that time you give 20 or 40 milligram of Lasix. That too, it's as a decongestant, not to bring down the BP. Do not treat Lasix as an antihypertensive agent. That is a key message I want to give you all. And the other very annoying thing that people often do is take that nifedipine and put it sublingually. It is not supposed to be done. I'll tell you why. Two things why this should not. These are old practices. It should not be done. They're unsafe practices. When you put nifedipine sublingually, the absorption is erratic and it will drop suddenly, especially when there is, a stroke or something where the guidelines are very, very strict. You're not supposed to bring down the BP very fast. So do not give Lasix unnecessarily. Don't put anything sublingually. This is a very, very important message I'm giving all of you all. Okay. Then your BP is 180, 110 as far as possible. This patient's BP is 180, 110. Try to make out which hypertensive emergency this patient has and you'll have to refer appropriately. If the BP is more than 230, 130 and all, you may, with monitoring, give a IV labetalol about 10 milligram as bolus. You may repeat it once more after about 10 minutes with double the dose, that would be 20. After this, perhaps you'll have to start a labetalol infusion. So if your patient is so sick and is heading towards labetalol infusion, etc., it is safest to refer the patient properly in a proper ambulance, and this patient will have to be monitored in a ICU, because studies have found that inappropriate dropping of the BP also is associated with a higher mortality, because the patient is used to such a high BP. What will happen when you drop it? Both the cerebral and coronary autoregulation will get messed up. So you can't, do damage to the patient. So the don'ts are almost as important as the do's. Okay. Which are the situations where a high BP needs rapid lowering of BP? Only one or two situations. In IC bleed also, the BP has to come down a little faster. Aortic dissection also, you can start that labetalol infusion and bring it down, and you have to bring it down to around 130 systolic. This is important. Okay. CNS meaning, if it's IC bleed also, patient will have to go to ICU. Stroke, infarct, don't forget. Today, if a patient comes to you with a stroke, ischemic stroke, and you do not thrombolize the patient when it's infarcted, we can be sued for not giving thrombolysis. Okay. Thrombolysis is an FDA class 1, level 1 indication. It has to be done. Make every effort to make the patient reach a stroke-friendly hospital. Okay. Because you can't, the patient has to reach in the window. Then only you've successfully done something right. Otherwise, you're really harming the patient. Okay. Hemorrhage also, I told you the BP will have to come down really fast. Roughly what I want you all to remember is, if it's an ischemic stroke, try not to bring down the BP too much unless it's more than 220, 130. If it's IC bleed, you'll have to lower it 25% in the first 1 hour, and over the next 4 to 6 hours, you need to get the systolic to 160. And only over the next few days, the BP has to come to 130, 80. You do not have to use magic wands to make a BP 220 into 130, 120, 70. It is utter stupidity. The BP would have dropped so much, but the autoregulation would have messed up like crazy, and you'll create lot of damage to the patient's brain and the coronary system. Do not try to get normal BP in most patients, except in aortic dissection, as I told you, or in pregnant women, or in IC bleed. Other patients do not need a rapid drop in BP. I hope I'm clear about that. Next, brain, I've somewhat explained to you all. In the heart, aortic dissection, I've somewhat explained to you all. These are emergencies. You have to refer very, very urgently the dissection of aorta and all. Next thing, which is little more in your hand, the next two things which I want you all to remember is ACS, meaning MI. If there is an ST elevation MI, the preferred drugs would be NTG because they are venodilators. And if there's pulmonary edema also, NTG is the preferred drug. If there is pulmonary edema, I want you to use not labetalol. Labetalol, I've told you for all the other things. And I've told you only two important drugs for all these emergencies is labetalol, NTG. Learn up these doses, stock them up in your whatever emergency or casualty or wherever. Use cognitive aids. Make small charts describing the labetalol and NTG infusion so that anybody can pick it up and do it. No need to waste time learning up the doses and all that. These are called cognitive aids. We will do that. Please do that, okay? I've told you about the brain. Now I'm coming to the heart. No, if there is ACS, ST elevation MI, again, thrombolysis or reperfusion is extremely important. Don't be in a rush to bring the BP down. You can use NTG. NTG, you'll have to put 25 milligram in 50 ml of NS and start at 0.6 ml. Here again, don't be in a massive rush to drop the BP. If you drop the BP, it will be very difficult to thrombolyze the patient. So you'll be very, very careful about that. That is one thing. Pulmonary edema. Next is pulmonary edema. JVP is raised, BP is 220, 120. Patient is tachypneic and patient is hypoxic. And when you auscultate, you find crackles all over the chest. Let's say this patient prop him up, start oxygen, supplemental oxygen, give Lasix 20. I'm telling you, I'm using Lasix to decongest the lung, not to bring the BP down. Lasix should not be used as an antihypertensive agent. Don't chuma give Lasix to bring the BP down. There is no joy in doing that. So the two no's that I've told you all is don't give Lasix to bring the BP down. Don't put anything sublingually to bring the BP down. You'll have absolutely no control over the BP. It has to be done under close monitoring in the ICU with an hourly BP with titration of whatever drips you all are using. Okay, I'm back here at the pulmonary edema. Give Lasix, give oxygen. If the patient is very breathless, you can put BiPAP also. You can use that NIV. And remember, NIV will also bring the BP down. And the patient is ventilated, that will also bring the positive pressure ventilation, that will also bring the BP down. So you'll be very careful about how you're going to use your BP medications. Pulmonary edema, it is preferable to use NTG and not labetalol. Okay, because NTG acts as a venodilator and will bring down the preload. Okay, so in the next 2 minutes, whatever I told you just, and remember, whether hypertension emergency or whatever it is, you will be able to really sort out the patient only in the next about 1 week. That's how I see it. Their mortality is very high if they're mismanaged, and the mortality even after discharge is very high. But before discharge, make sure that you evaluated for secondary hypertension, explained all the BP targets to the patient, medications are explained, medication adherence is counseled for, everything is done, and make sure that the patient doesn't come back to you with another hypertensive emergency because it costs lives, hypertensive emergencies. Okay. All good so far? I've tried to give the key messages, okay? Can you all say yes if you all have gotten the key messages? And then I'll quickly summarize what I've told you all. Yeah. So what did we learn today? We learned that long-term BP control is of paramount importance. All patients over most ages should have a BP of 130, 80 at almost any time of the day or any place. Wherever you meet or check the BP, it should be around 120, 70. The targets are coming down, are being lowered very fast. However, in our clinical practice, we come across patients who have a high BP. They can come to you in two formats. One is in your OPD, there are no symptoms, you just check the BP and you found the BP to be 180, 110, whatever. Check it again, reassure, do everything. Safest antihypertensive. You don't need to bring the BP to have 110, 70 in 1 hour. Not required. It should come down only in a week or two. Asymptomatic severe hypertension is not associated with any increased mortality as long as you're able to address the BP in a week or two. Okay. You don't panic and don't make the patient panic when there's asymptomatic severe hypertension. Second part, what did I tell you? Hypertensive emergency is a very, very high mortality situation. Make the diagnosis and find out what the ATOD is. ATOD means acute target organ damage. What I told you is the most common: brain, heart, eyes and heart. So this has to be treated like your red zone, in your red zone, emergency in your red zone. And what did I tell you? Most of the times, BP should not be dropped very fast. Roughly, a key way to remember it, 25% in the first 1 hour, then bring it down to 160 in the next 6 hours, and normal BP should be seen only in the next 1 to 2 days. No need to hurry up in bringing down the BP. What are the don'ts I told you? These need referral, they need ICU monitoring because they're very, very, very sick. These patients will be hypertensive emergency, is a very serious emergency. So be absolutely vigilant. My suggestion to you is all of you find out where there is a tertiary care hospital which is stroke friendly and which will thrombolize both either brain or this, because human beings, they don't live without brain or heart, okay? And it's our job to make sure that they don't lose brain or cardiac muscle just because we have not. So tie up with these hospitals, have phone numbers, do emergency referral, because time is brain and time is muscle, okay? Hypertensive emergency, what are the key things I told you? Identify whether it's brain, heart, or kidney, and lower it down appropriately. What are the don'ts I told you? Don't use Lasix as an antihypertensive medication. It is not an antihypertensive medication. Lasix can be used only if there's pulmonary edema to decongest the lung, okay? Then the two drugs that you need to remember is labetalol. Labetalol can be used in most medical emergencies, and the wonderful, fantastic thing about labetalol is very short acting. So even if you drop the PP, it won't become precipitously low that you develop hypertension and make the patient basic. That will not happen. So you remember labetalol, find out the doses, make posters, and put it in your casualty. Labetalol. Second drug that I told you is NTG, to be used in case the patient has pulmonary edema. That is a drug of choice. Okay. Eventually, before discharge, make sure sugars, cholesterol, everything is done. Patient's dietary, lifestyle, everything is done so that the patient doesn't come back with a sinister event like this. Okay. All the best, yeah. See, BP and sugar are two big problems in our country. If we are able to manage BP and sugar according to proper guidelines, learn the do's and don'ts, we can really do a big service to our patients. Each of these topics that I give you actually warrants a half-an-hour talk, but I hope I've conveyed the key message to all of you. Okay, and thank you so much for having me here, because these are topics that I want to tell you. Okay.
Thank you so much, Dr. Soumya. That was excellent. Even without a PPT, you managed to get the point across very well. Anybody has any questions, you can put it on the post, and if ma'am can hang around for a bit, you can answer any questions that she has. The recording, everything can be shared with them later if they'd like. Yeah. Thank you so much, ma'am. We'll move on to the next one. So if you've always wanted to know how you could actually do research and collect data in a rural setting, the next talk is for you by Dr. Royson D'Souza, who's a consultant surgeon in the Ashwini Gudlur Hospital, and he's also the Global Health Associate Director of BMJ Case Reports. So Royson, can you start, please?
Good evening, everyone, and thank you for this opportunity. The talk that I'm presenting is generally a 2 to 3 day workshop in most hospitals. I'll see what I can do in 15 to 20 minutes. Nevertheless, it's a very important area for all of us as doctors, because as part of being doctors, we have to be researchers, because unless we are constantly thinking about our work and what's happened and what's going to happen, it's just part of our professional role. So why research at all? So I remember when we were medical students, we had this fantastic research mentorship program, and this was the first thing that Dr. Ramesh and team put up. Research is nothing but answering something scientifically. You have any doubts, anything that in your daily practice is bothering you, why this, why not this? You conduct something systematically in a scientific way and you answer it. That's research. And it's nothing but you're like telling a story to the world. And it can help people know your expertise. And also what I like the most about research in rural areas is it helps colleagues dealing with similar situations in probably another corner of the world. And at the same time, for our other colleagues who are in tertiary care, and also for all of us, apart from the promotions and career opportunities, it helps with recognition, and when you get an email saying paper accepted, it's very rewarding. So I'm sure many of you know this pyramid, which describes the types of medical literature. So expert opinions or background information are something that have the least quality of evidence, and as compared to meta-analysis and systematic reviews, which are like the top class. So all protocols and standard of care, everything is based on research, based on systematic reviews and meta-analysis now. So apart from these, there are also some other types of medical literature. So essentially what I'm doing right now, that's also something, medical literature, conference presentations, lectures in colleges, talk shows, textbooks, writing for newspaper articles, etc. But what makes this pyramid more strong is that it's peer reviewed. So research publications happen only when it's reviewed by a series of referees and editorial team, and that's when it gets published, which makes it much more stronger than the other counterparts of medical literature. So how do you start? I know it's a very for those of us who've had a try at getting a paper published, it seems very tedious with series of questions like, is it relevant, and which journal, why this topic, is there something better than what I have, and also dealing with the problem with the language from our side of the country, because the British journals will want British English and the Americans want something else, and all sorts of problems. But then it is a fun process when you start. Coming to the rural settings, of course, it's got its own challenges. First of all, is it possible? Many of us must be wondering, okay, I'm sitting in a 20-bedded hospital in this corner of the world without a CT scanner, MRI, or histopathology. So how am I going to publish? So yes, there are challenges. I personally feel it's definitely not inferior compared to what the medical colleges do or tertiary care centers do. There are diagnostic challenges. The numbers may not be as big, and we don't have a whole department of statistics and statisticians to help us do our analysis. Most rural hospitals may not have a IRB or an ethics committee. So to do something which needs clearance may be challenging. And of course, always this question of whether what my rural hospital is doing, whether it's standard of care. Actually, in research, that's a good thing, that most journals are not bothered whether your research is standard of care. Like, what they are looking at is what different is your study compared to what is standard of care. So it's always about how we put across our point. So there are definitely some advantages. If you look at most comprehensive big original articles, they will have at least 20 to 30% of patient being lost to follow up, which actually which interferes with the results. In rural areas, I feel that the patient compliance and follow-up is fantastic. So that's an advantage. So if we have 100 patient follow-up, we may be able to follow them up till the end of the study, all of them. So that's an advantage. Again, there are centers, I know bond centers which have specifically leprosy care, dermatological care, rehab units, psychiatric cares, palliative cares. For example, our hospital is a sickle cell center. So essentially, if we were to, we have series of studies on sickle cell. So just to say that if your bond hospital or if your rural hospital is a unique specialty service, the number that you may be getting there may be bigger than what AIIMS Delhi is getting. So that's what you need to take advantage of when you say, dealing with a particular problem and doing research in that particular problem. And there are journals which specifically look for submissions from rural areas. For example, BMJ Global Health Case Reports that I am associated with specifically wants, research to come from rural areas. Then there is a Christian Journal for Global Health and many more. You can always look them up. Last but not the least, I find that we have a lot of time in rural areas to, sit and do something beyond just the clinical work. And in researches, if research is one of your areas of interest, there is plenty of time for it. So next question is what to publish. So like I mentioned earlier, in rural areas, we don't have numbers, but at the same time, most publications or most journals don't look for numbers, and because most of them are saturated with numbers and new and rare and all of that. So many look for what is different or how can this be managed in a rural setting. So that's something that I personally enjoy. Like take a complicated case. I mean, obviously that can be managed in a secondary care hospital and then write about it. One thing, yes, the journals get excited to publish these things. And more importantly, if there are people who are working in a similar healthcare setting, they will definitely benefit from what you have published. So new and original methods, reviews or summaries of relevant subject and studies that can enhance knowledge in a particular field. And if there is already a method, if you have an alternate method that makes it easier, so that's something that's good to publish. What not to publish is reports that are not of scientific interest, things that are clearly out of date, duplications of previously published work, because that can blacklist you and you'll never be able to submit to a journal again. And again, incorrect or unacceptable results. A good way to start your research is by doing a literature review. Google search engine is pretty good nowadays, especially with AI feature. But for medical literature, definitely look beyond that. So these platforms are pretty handy. You may have to subscribe for few, but many others are available to be browsed easily. So if you have something interesting in your hospital, always look at what is already available and what's different that you are trying to put across. And that's when it's this literature review comes handy. Likewise, choosing the journal. So if you have a clear-cut case of psychiatric disease and then you want to send it to a journal of surgery, obviously the journal is going to be very upset. So I find this platform very useful. This is something that was told to me when I was post-MBBS doctor. So you just Google JANE, JN Journal Estimator, and then you get a box here where you can paste whatever. You can paste the title that you're interested in. You can paste your abstract. You can just paste keywords. For example, if you paste, inguinal hernia complications or absent external oblique muscle during inguinal hernioplasty, and you get a series of journal recommendations like this, and you can click on each of them and see. You can even find out which are paid for, which are free, and what is their impact factor, etc. So that's something that's pretty handy. Another thing that I suggest is once you narrow down your journal, read what that journal is recently published, at least the last 2-3 editions of that journal. Because if something similar to your topic has been published, and you can make the editors more interested in your article. So some common problems that the editors deal with is, like I mentioned, submitting papers that are not journals focus, and not formatting the paper according to the guidelines for the authors. Every journal has their own guidelines, so it's very important to sit and spend some time reading those guidelines. Often the paper doesn't get accepted the first time you send. There'll be some doubts, queries, and reviewers' comments. So we often see people respond saying changes made without mentioning where the changes were made, etc. So that's something that can irritate the editors. English language is a major problem, but now with Grammarly and other tools available, I think it's a bit easier. And submitting a manuscript that has been rejected by one journal is something that can be a problem. So this is how most manuscripts look, except for case reports, which don't have methods and results section. So it's important. The reason I put this is that the journal article is not a novel where people are looking for beautiful English and description, etc. It's a research paper is something that has to be very explicit, where you are to the point and tell what you want to tell, rather than come around and then describe in an indirect way. So title and abstract have to be very informative, accurate, and attractive. Introduction has to be very clearly what is already known, what is not known, and what is your research that is going to answer. And methods also, the design, the setting, data collection, etc. And in the results section, start with the results itself instead of, again, going back to the introduction or other things. So will be the discussion. The discussion should start with our study found this, rather than in 1980, this was the problem, or something like that. So although the final paper looks like this, when we prepare a manuscript, it's a bit different. So it's always easiest to write the title at the last. It's easiest to start with the method section because that's something that we do during our data collection, etc. So we start with the methods and then write the results, and then write the introduction, then discussion, abstract, and title. So this is something that's a little more easier to write with. And then, of course, when you submit, you reorder things and submit. So make use of illustrations. So just to give you an example, one of our rural-born candidates last year fantastically managed a patient with severe burns in a rural hospital, in this 10-bedded hospital. And when we wrote up, so one of the things that I wanted to highlight here is in the paper, we wanted to say how burn centers are very rare in India. So we had this big paragraphs like how burn centers are so sparsely located, patients don't make it on time, etc. But we could just change it to this image here with a map of India showing where the burn centers are, and which is very self-explanatory. So use a lot of illustrations when you are writing a research manuscript. And also illustrations like flowchart rather than long paragraphs. This will attract journals and editors because they know that, okay, you have put in some more time to make it more attractive. Obviously, if you're going to use someone else's illustration, you need to get permissions from them, but best is to do your own illustration. So what happens after you submit a research paper? Generally, the initial decision is either rejection, unfortunately, or review. So once the editors decided to send the paper back to you for review, you need to answer their queries and write back to them. And then there is sometimes the paper can go for review twice or thrice before a final decision is made. So once the final decision is made, then the article gets published. So most journals will have online preprint before the final version. So yeah, so that's how it goes. So like I said, first reply being accepted is extremely rare, especially if it's a high impact journal. If it is, then congratulations and fantastic work. But often about 40 to 90% of the time it gets rejected. Don't be too upset because it happens to everybody. But very important is to try to understand why your paper got rejected. And often the reasons are mentioned in the email that you get. And try to work on them, improvise, and then if you want to submit to another journal, but make sure you incorporate the changes, because often if you send to, let's say, Indian Journal of Medical Research, and then you get rejected for your paper on tuberculosis, and then you decide to send it to Indian Journal of Tuberculosis. So the editor-in-chief of Indian Journal of Medical Research is a reviewer for Indian Journal of Tuberculosis. And then they will say, I had rejected it last time, I'll reject you again because you didn't make any changes. It's happened to me before, and it can happen. So yeah, make the changes that's been suggested before you submit to another journal. Some practical points, last 2 minutes. Ethics is very important, especially for clinical trials, that you need to get ethics committee to clear your paper. So if you do not have a ethics committee in your hospital, one thing you can do is you can go to a close-by ethics committee or IRB, or you can go to the IRB at St. John's. Consent before starting study and consent from the participants is very important. And for RCTs, randomized control trials, there needs to be CTRI registration. So some things that can blacklist you is submitting to multiple journals at the same time, plagiarism, falsifying data, or not sticking to author guidelines. And some other practical tips of writing, like I mentioned, it has to be explicit. For example, if his eyes are blue, you write his eyes are blue and not his eyes reflect the color of the sky on a sunny day. So that's not what a journal would want. It has to be to the point. Similarly, as researchers, we always want to write systematic reviews, meta-analysis, because we know that's right there on the top. But my suggestion is that there's no study design that's inferior. Case reports, although very low on the order, are excellent way to start your research career, especially in rural settings, because often we don't have the numbers to do big studies or the funding. Remember, research needs a lot of funding also. But case reports is not inferior, so that they are a good way to start. And when to start publishing, I think there's no there's no doubt about that. That earlier the better. In my opinion, research is like learning a musical instrument or like swimming. Earlier you start, the better you get. The longer you wait, the harder it is. So credit to the research department of St. John's, which started this fantastic program way back, I think about 15 years ago, if I'm not wrong, and were the first in the country with excellent curriculum and everything. So that's really where my interest in research started, and I've never looked back. So thank you, the alumni team and everybody for your patient listening. I know it's the last topic that we want in a rural health CME, but it is nevertheless, it's a very, very important topic. Thank you so much.
Thank you so much, Royson. I know it's a lot to cover, and it's a lot for people to get, but you've managed to make it very simple and very interesting. So thank you so much.